Starting with the next session, may I invite Dr. Kapil Kulshresth. Dr. Kapil sir, Dr. Rajendra Singh Gahir, Dr. B.D. Chatterjee sir. So please come on the stage.
I'll take it from what the discussion that I had with Dr. Prasad. He was wanting this meeting to be more case-based. So I did make a collection of certain cases, but I'll stick to very, very specific points. I mean, Dr. Anil just presented a complete presentation on a valgus knee, lot to cover. I'm just going to try in this first case of mine address one of the methods of correcting a valgus knee that I, in my practice, have found to be very, very effective. And if you go through the algorithm that Dr. Anil suggested, is that the first and the foremost structure that he corrects also is the iliotibial band. So I'm just going to sort of go through it. And we all know that a valgus knee is typically valgus in extension. Usually the valgus knees that we see, majority of them less than 15 degrees. And if you see, as they flex the knee gets to neutral and sometimes even in kind of varus. So all these knees are usually tight in extension laterally, but they are reasonably well balanced in flexion. This is just another case. Again, you see valgus in extension and then comes down to about neutral in flexion. And when we sort of do these cases and you do everything as recommended in terms of a minimal distal resection on the lateral side, your way of doing a valgus knee, and as you will do your way of doing a valgus knee, what you will find is that the knee is reasonably stable in flexion, but the moment you extend these knees, they are unstable, and this is kind of a picture that you will see. So you will see that, I don't have a pointer here, but essentially you will see that they're approximated laterally, that's the tight part, and they're loose medially. And if you look at them from a distance, they will appear to have a fixed flexion deformity. And that fixed flexion deformity that is left in these knees is primarily because the knee is tight in extension. And if you do a good release for structures that are tight in extension, you will find that the knee extends fully. And as you can see here again, it's tight laterally, touching, approximating, and there is obviously some gap that you can see on the medial side here. And what we want to do is we want to correct this imbalance. Now we know that there are several structures that we can use. We talk about when we talk about balancing a valgus knee, but a valgus knee that is tight in extension, iliotibial band, in my opinion, should be the first sort of structure to be addressed. And while there are several described techniques of addressing the iliotibial band, the one that I have found very, very effective is an extra-articular, extra-synovial release, which is something that has been sort of propagated by Leo Whiteside. And I'm going to show you how we do it. So if you look at the iliotibial band, and this is his paper, there is a central band that goes on to insert onto the Gerdy's tubercle. And the iliotibial band, posterior part of the iliotibial band is typically very, very tight in extension. There is an interior part of the iliotibial band that adds a little value, little tightness in flexion, but majority of tightness that comes from the ITB is during extension. If you try to release the ITB at the level of the joint line, there is a high risk that you might damage either the LCL or the popliteus or structures of the lateral side, and most of the people who are trying to release it inside out are always worried that they might end up releasing a little more than what they want, because the amount of correction that we are looking at is not huge. So the described technique, and I'm going to show it in this video, is how to do an extra articular, extra synovial release of the IT band, and I will show how well the correction is achieved just by that procedure. So we're going on the outer side of the patella so as to isolate the ITB. So I'm just going slow so that everybody can see what is done. So what we, I don't have a pointer. Yeah, it's not showing the arrow. That's the problem. Okay. Yeah. So that's basically the. So anyway, so what we've done is now, obviously this is, okay. So I'll keep it small. So obviously this is the head end, this is the foot end, this is the patella here, and this is the ITB that is coming from here and going and inserting into the Gerdy's tubercle somewhere there. This is the anterior part of the ITB, and somewhere down there is the posterior part of the ITB. In extension, typically it is the posterior side of the ITB which is tight and which is preventing this full extension from happening. So what we've done here now is we make a small incision in the ITB, extra synovial. We've not gone through the synovium, we've just gone through the ITB. And then we can try and palpate the tight posterior part of the ITB. The more posterior you go, the tighter is the ITB down, and that's the part that is preventing us from getting full extension. So this is the anterior band that is loose in extension, and this is the posterior band which is tight. It's still. I don't know if it would have been great if you know there could be sound played, and as you release the ITB band, you can actually hear how well it sort of gets released. So you keep going down, and it gets tighter as you keep going down. That's all the way till you reach the biceps. And then the last bit, and that's now completely, so the posterior part of the ITB is completely released. These are the images. The one at the top is before the ITB release, and you can see that the leg is still held in flexion because the tight lateral structures are avoiding it from going into complete extension. The image at the bottom is after the ITB release, and that's where the tight lateral structures have been released and we are able to achieve full extension. And again, I'll just sort of show, if you remember the image from before, there was an opening on the medial side. That was because the tight lateral structures were not allowing us to go into complete extension. And this is after the release. There is the gap that was there on the medial side has reduced. And again, this is with the final implant in place. So this is in flexion, and and as it's extended, once again, we can see that once the ITB band is released, the gap on the medial and the lateral become equal. So I just wanted to demonstrate this one technique, which is a technique to sort of balance a valgus knee from outside in. It works for a majority of cases, and it's a safe and effective technique to do. Since I have a bit more time, I'll just move on to sort of demonstrating another thing that we were talking about, the rotation. So now if you see a knee like this, and we talk about 3 degrees of rotation or 5 degrees of rotation or 7 degrees of rotation. Now if you, sorry, going back. If you actually look at the image here, this is probably where the true posterior margin of the medial condyle is, and this is an overgrown osteophyte on top or on the medial side. If you were to set a rotation of 3 degrees here, the component is going to be in internal rotation. You can draw a transepicondylar axis and get the rotation right, but as I said, drawing a transepicondylar axis may be a task, so you could use the right side line. But essentially what I'm trying to show here is that you've got to be aware when you're setting the rotation. One of the options is to take a tibial cut and then measure it parallel to that. That is one technique. The other obviously is to draw the transepicondylar axis and then get the rotation right. This would probably end up somewhere around 7 degrees of external rotation. This is another case. I don't think I've got the videos here, but because once you're doing it navigated, you sort of see how the flow goes. But essentially, this is probably one of those cases that I've highlighted where we used a 0 degree rotation, because so even with a 0 degree of rotation, you get the balancing reasonably good. This is again demonstrating the same concept, and this is what I wanted to bring forward here, was that a lot of times we see that the knee has a fixed flexion. You know, after you put the components in, we put the component in flexion. As we bring it to extension, we see that the knee doesn't fully straighten up, whether it's a varus or a valgus knee. And if you do correct the imbalance which exists, you will get full extension. So even before doing the standard concept, okay, the knee is tight in flexion, let's do a more extensive posterior release. Before you do a posterior release, also make sure it's not the tight medial or the tight lateral structures that are preventing you from getting a full extension. So again, something in FFD, you correct the deformity, you bring restore the balance, you will get full extension. I'll pause here. There was this another case of, which has already been discussed in the morning, about a stress fracture, a normal tibia looking X-ray, but if you look right at the bottom, if you keep, there is a small defect here that you begin to see. There is a defect here that you start seeing, which may be missed on a normal X-ray. But if you have a long leg film, and you can see that there's a fracture line here and probably a fracture line extending here. That's the fracture line here, that's the fracture line here. Now this is one of those cases where I should have used a plate, because once we finish the surgery with the rod, as you can see, the rod, the stem extension, that's the extent of the fracture. Now where I anticipated the fracture was somewhere here, we didn't realize that the fracture was extending all the way down here. So this is where we anticipated where the fracture line is, and therefore bypassing the fracture line with a significant degree and correcting of the alignment would have been sufficient according to me when I did the surgery. This is what we realized post-operatively. But again, if you look at it, this is where the fracture line was immediate post-op, and this is delayed post-op. It has healed completely. This is where the fracture line is immediate post-op, and this is post-op, delayed post-op where it has healed completely. So bypassing the defect and correcting the alignment itself will allow the fracture to heal usually. Thank you very much.
Dr. Mudit.
Yes.
Here, chairpersons. Here, on the chairs.
Sorry.
I don't think many people would be doing this extra synovial release of ITB. It was a very good demonstration. What is the criteria of you're selecting for going for the extra synovial versus the inside one?
So, I mean, if you ask me today, if I do exactly a valgus knee like anybody else would do, I put the component flexion, I take it into extension. If I take it into extension and I see what is sort of a situation where the knee is not fully extending, it's tight laterally, the medial side is slightly off, I would go straight away for an extra synovial release. We've probably done about 50 cases now. It works like magic. It takes only 5 minutes. And I'm sure somebody else may have experience with an intra-articular sort of release of the ITB. I, in my practice, always struggled to get the kind of release that I wanted to with an inside-out technique. The outside-in technique has significantly reduced the amount of releases that I have to do while addressing the lateral side. Using lamina spreaders, even the amount of lateral release or the posterolateral corner release has come down, because the moment you go all the way down releasing the ITB up to the biceps femoris, it corrects majority of the deformities.
Yeah, I have a question that at what point of time do you take this decision to go extra-articularly? Do you plan it pre-operatively, or do you take an intraoperative
Intraoperatively, absolutely intraoperatively. So, I mean, I would say this would be my first sort of release that you decide. If you're doing a varus knee, you decide whether you need to do a release or you don't need to do a release. If I do need to do a release, my first step to do a release would be the extra-articular release of the ITB. And as I said, majority of valgus knees just balance beautifully just by doing that.
So the reason I ask this question is, do you actually plan a lateral parapatellar approach in these?
No, I would even go with a, I mean, it depends. I don't do a lateral parapatellar approach at all. If I were to do, I either do a subvastus or a medial parapatellar, even in a valgus knee. I don't think that really makes I think somebody should use a lateral approach if they are familiar with the approach. I myself am not familiar with a lateral parapatellar approach, and therefore that's not part of what I do. But I have done valgus knees with a subvastus approach, and wherever they've been issues with balancing, majority of the cases do respond if they're tight in extension only, and which majority of the cases
I think we have questions from Dr. Hardy.
How do you decide between the anterior and posterior compartments of the ITB?
So
because it's a very thick, strong structure, and it can be very difficult to decide where it is.
So the answer to that is, there are two parts to that answer. One, you don't really need to. The anterior part adds a little stability in flexion. So if you actually take off both the anterior and the posterior part, it works fine. The second part is that you palpate, because you can easily palpate where the sort of lax structures are and from where it's beginning to get tight. Wherever you feel it's beginning to get tight, that's the line you draw. That's where you incise and then start going directly posteriorly from that point.
Mudit, I like your way of thinking. My apprehension is, I am very, very skeptical about elevating flaps in knee surgery. Elevating flaps in knee surgery, particularly lateral flap. At least once I burnt my fingers very, very badly, where in a valgus knee, I wanted to release common peroneal nerve, and I tried to act smart, lifted the flap all the way and released my nerve, and had a big, massive skin necrosis of the lateral flap. I mean, in routine surgery, I don't even lift it up to the patella. I just turn everything around.
So I completely agree with you. In a routine surgery, I don't dissect I don't dissect anything on the lateral side. You know, midline, I let everything be attached to the lateral side. And even in this knee, if I were to do it, initially the entire procedure will be done. The entire procedure will be done till the point you extend the knee, and if while extension, that's when you realize that you need to release something. That's when you start dissecting. So for this knee, I mean, I just took the video, I think, a few days back. I don't use a tourniquet. I used a tourniquet because I was dealing with a valgus knee and I wanted to demonstrate the technique, and that's why I used a tourniquet. It was a disposable tourniquet. We realized that this is where we might end up needing, might get an opportunity to demonstrate, and that's why we use this.
So, do you think I would go extra incision, like make another small incision there to just release it?
No,
from
it's
outside? I'm worried about elevating that flap.
No, it's a flap through a natural plane. I mean, I would not want to sort of develop a plane if not necessary, but as long as it's right where it needs to be, it provides a good coverage. I haven't had any issue with in a valgus knee where I've sort of used this approach in terms of wound dehiscence or necrosis or anything of that sort.
Good technique, Mudit. Sorry, just one quick addition. How close or what precautions do you take for the CPN at that level?
So the CPN is behind the biceps femoris.
Correct. It winds around about 5 centimeters proximal.
Yeah, so
because the structures are all contract on the lateral side, any particular precautions?
I mean, I wish you could hear the sound as it was going through. You know, when you're releasing these structures, as you go through the iliotibial band and you keep following it and you keep palpating. So it's small steps and keep palpating, small steps and keep palpating, and then you suddenly get that give way the moment you release it, and you still have the common peroneal nerve protected by the biceps femoris.
But bicep will create sound.
No. There's a distinct plane. You will not extend into it. There have been, so it's even documented to release the biceps if you are still not getting sort of enough correction, because once you've released it and then you can palpate the biceps, sometimes you can find a tight biceps which is preventing that last bit that you want to get. That's when I would be scared. That's when I would be worried about damaging the common peroneal nerve. Though it does seem scary to think that you might be getting there, it's reasonably far. I don't think, as long as you're going step by step, it's reasonably safe.
I think we should go ahead with the next lecture and we can continue this.
But thank you. That was excellent video.
Oh, thank you.
Modi, that excellent video you showed. Yeah.
I'm going to talk about constraint in TKR, how to decide what level of constraint you need to use. So constraint is defined as a device that stops something from moving. It's a dictionary definition. So you look at normal knee and the arthroplasty knee. In a normal knee, the stability is provided by the ligaments, MCL, LCL, ACL and PCL, articular geometry and proprioception. In arthroplasty, the ligaments are either resected or released, and the articular geometry is provided by the conforming poly, and some constraint is added. If you use a substituting, sometimes you use substitution for the ligaments. So I'm going to talk about constraint in primary TKR and constraint in revision TKR. If you look at the kinematics of the knee, there is sliding and rollback. So the rollback starts at 30 degrees and the femoral condyle slides and rolls on the femur. And the biomechanics is controlled by a 4-bar linkage. The 4-bar linkage includes ACL, PCL, quadriceps tendon, patella and the patellar tendon. So we need to replicate this in a prosthetic knee. So look at the arthritic knee with the intact ACL. What would you do? So this, we do a partial knee replacement. If the ACL and PCL is intact and only unit compartment is involved, we do a partial knee replacement. This is the least constraint we can do. This is an example of anteromedial OA in a non-inflammatory arthritis. How do you decide? You have a medial bone on bone. Your medial bone on bone your lateral joint space is intact on a valgus stress. In the lateral view, there is ACL is intact. So your contact point should be in the middle or anterior, it should not be posterior. That means your ACL is intact and your MCL is intact. It does not open up beyond a certain limit, and there is no bone on the skyline view. So we do a uni-compartment knee replacement. Either you do a fixed bearing or mobile bearing, and there is no constraint in this type of prosthesis. This is totally unconstrained. You get full range of movement, natural joint proprioception, range of movement and stability. This is a post-operative X-ray. So recovery is quite fast. You don't do any soft tissue release. Patients start walking the next day. They get you good range of movements. This is an example of one more bilateral medial bone-on-bone anteromedial OA, bilateral unicompartment knee replacement. You can see the alignment is always under-corrected, not fully corrected. You can do either a fixed or mobile bearing. It's up to you, your surgical technique and your training. So you need to identify when the ACL is deficient. The X-ray on the right knee lateral, you can see the contact point is posterior. There is some posterior osteophytes. Compared to the left side, the contact point is in the middle third. That means your ACL is intact. So in this scenario, we need to do a total knee if the ACL is not intact. So here you can see the alignment correction. We try to get a neutral alignment if you do a TKR. If you are doing a partial knee, you undercorrect the deformity. So now we are going for TKR. When your ACL is deficient, you are planning a TKR. Generally, TKR are ACL deficient knees. Then we need to provide rollback and AP stability. So this is done by the prosthetic design, then by restoring the PCL tension. So when you are doing a CR knee, you should restore your PCL tension. If you are not restoring the PCL tension, it's going to fail. So there is some stability from the prosthetic design also, and you have additional deep dish option if you are not able to restore the PCL strain. Then we move on to the cam post mechanism. When you are not able to balance the PCL, you substitute with the cam post mechanism. So the cruciate substitute in knee, both ACL and PCL are removed. The PCL mechanism is substituted by a cam and post, and it starts engaging from 60 to 80 degrees. It stimulates natural rollback and provides stability and good range of movements. Both these designs have curve-on-curve pattern. There is some inherent constraint in the design itself, both medial-lateral and AP, and both have some amount of constraint. So this is an example of bilateral ONE with varus, where I done bilateral PCL retaining arthroplasty. So the mechanism, the mechanical axis is restored, the alignment and component placement is good. But if you don't balance the PCL well, there is paradoxical rollback. So normally your PCL contact point is should start anterior. So you have a pointer? Okay. So your contact point should be anterior. You can see the image on the top right. The contact point is posterior. That means the PCL strain is not restored. And when you start flexing, it rolls anteriorly. It's called paradoxical rollback. And this can cause excessive wear. So if you're not balancing your PCL, you can have a early failure. So coming to posterior stabilized knee, most of your primary TKRs can be done through with your posterior stabilized prosthesis, especially in Indian patients where there is severe deformity and bone loss. You try to use a posterior stabilized prosthesis. So this patient has severe varus, medial bone loss. So this has been treated with the posterior stabilized knee. The biomechanics is very predictable, and you're able to restore the alignment. One more case, fixed varus, where the deformities has to be corrected with the soft tissue release, where we used the posterior stabilized prosthesis. One more example where there is excessive lateral opening. You can see the lateral side is so much open, you cannot balance with just medial soft tissue release. So I've done a navigation assisted posterior stabilized prosthesis with a medial sliding epicondylar osteotomy with a postoperative alignment. Similarly, in mild valgus, you have an option to use either a CR knee or a PS knee. In this case, because it's a correctable valgus, I use a PS type of prosthesis. But you have a severe valgus with bone defect, again, you can go for a posterior stabilized type of prosthesis. Here we have used a PS knee, and the deformity is corrected and well balanced, alignment restored. So when you compare PCL retaining knee with a substituting knee, both implant designs are comparable, and very specific indication for a PCL substitution is severe valgus. post-petelectomy, and severe flexion deformity. In severe flexion deformity, you want to reach a posterior capsule, we need to release the PCL. Then post-petelectomy, there's a lot of strain on the PCL. Patient has been walking, post-petelectomy patient, they have a lot of strain on the PCL. The PCL can be undergone attrition or fibrose. And severe valgus is always difficult to balance with a CR knee by doing a soft tissue release. So next level of constraint is a varus valgus constrained knee. So here you compare to the PS knee, the box is taller, the post is wider and taller, and it has an increased jump distance. From 16 mm, it increases to 20 to 23 mm. So it provides some amount of mediolateral stability, but does not substitute your collateral ligament. It does not substitute for your MCL or LCL. Some amount of laxity it can take care, but it cannot substitute. So this is a case of severe varus deformity. You can see the lateral collateral is stretched, and balancing the mediolateral gap is difficult. So we are restored to a varus valgus constrained device. So already we discussed earlier, we have some amount of medial or lateral laxity. This can be taken care with the varus valgus constrained design. This is a severe valgus, lot of medial opening, but MCL is still intact, is doubtful. So I opted to use a varus valgus constrained device with a sliding epicondylar osteotomy. So in a younger patient with severe deformity, you don't want to use a hinge knee straight away. So you use a slightly varus valgus constrained design. If necessary, you combine with a osteotomy or a soft tissue reconstruction. The severe fixed flexion deformity, we already discussed, there is high chance of mid-flexion instability. So here we need to use a slightly more constraint. So the varus valgus constraint prevents mid-flexion and flexion instability. The post helps in providing stability, especially in flexion. So ligament reconstruction, where do you use ligament reconstruction in primary surgery? Only incidents where there is intraoperative injury for the of the MCL, we use this direct repair and hamstring reconstruction. So this is an example of severe varus where there is intraoperative mid-substance tear. Actually, I excised part of the ligament with the medial osteophyte, so I had to do a hamstring reconstruction. Anytime you are using a PS, better to increase one level constraint. If you are using a CR, then it provides secondary stability. We can go with the reconstruction alone. So where do we use the next level of constraint? A rotating hinge or a totally constrained type of processes. Example of severe valgus deformity in a rheumatoid patient. Deformity is not correctable on a varus stress. Very osteoporotic bone. Here we don't try to balance it. We go for a hinge type of joint. So in severe valgus more than 20 degrees, MCL is incompetent. Dysplastic type of deformity, we go for a hinge. Again, valgus with recurvatum, post-septic sequelae, you can see the valgus deformity. Patient is walking with a recurvatum. These are severe cases which we cannot balance with a conventional implant. So this is a patient range of movement, patella laterally subluxed. You can see the recurvatum, see the amount of instability. So you approach through a lateral approach, tibial tubercle osteotomy, shorten the bone to get a ligament balance, medial shifting of the tibial tubercle, then closure of the lateral soft tissue with a mesh, and final closure. This is a post-operative X-ray. So severe valgus with recurvatum, rotating hinge is a better option. Neuropathic arthritis, where the patient does not have the proprioception, you need to give some substitution. So in these scenarios, a rotating hinge is better, otherwise they fail very early. This is an example of a neuropathic arthritis treated with a rotating hinge. So constraint in primary TKR, any simple primary osteoarthritis or rheumatoid arthritis, you can use either a CR or PS. Posterior stabilized knee is particularly indicated in post-petelectomies in severe rheumatoid where the PCL is degenerated and substantial preoperative deformities. Varus valgus constrained design implants are useful when there is severe coronal plane deformity or there is mismatch within the flexion extension gap. Rotating hinge implants are useful when there is severe deformity or instability which cannot be managed with varus valgus design. We move on to constraint in revision. Instability is one of the second most common cause for failure. So after aseptic loosening, instability is one of the common causes. So you need to evaluate the causes for instability, whether there is flexion extension mismatch, component malposition, or ligament insufficiency, or extensor mechanism insufficiency, or global instability. So these are the various causes: component malrotation, MCL insufficiency, extensor mechanism rupture, or global instability. Need to do a physical examination and a proper radiological evaluation. Stress X-rays are useful. CT scan and examination under anesthesia are useful. The treatment options include poly exchange or a revision. So poly exchange is very rarely used in an instability scenario. In the early post-operative period, if you see there is asymmetry of the gap, we can go back and do a proper soft tissue release and go for a thicker insert. It should not be done in the late case. So if you identify the instability in the early post-operative period, you do that. So sometimes you have a CR knee which is failed, you go one level constrained to a PS, mild instability post-CR due to wear, converted to PS. PS design revision, we go one level up to constrained design. Again, late failure aseptic loosening treated with a constrained design. If there is MCL deficiency in the revision scenario, there is no other option except a hinge type of joint. Here ligament reconstruction does not work. So the example where in a primary TKR the ligament reconstruction has been done, patient is stable in extension, in flexion it's grossly unstable. So it has to be revised to a hinge. In gross bone loss where the collateral attachment is lost, there is no other option except going for a hinge type of processes. So coming to the conclusion, constraint in TKR is useful in complex situation, but is not a substitute for good pre-op planning, good TKR basics and good surgical technique. Thank you.
Thank you. I think we should aim for maximum stability in the least constraint design.
Yes.
This is the message. Any question from the house?
It's an elderly patient, they are all 65, 70. For a younger patient, I would recommend a H2O. Probably at 60, 65, uni works well. It has a longevity of at least 15 years if it's well done. So I recommend a uni compartment replacement.
Dhanshik?
No, these two are two different groups. One, young and active patient who requires squatting, heavy activities, we recommend a H2O. A middle-aged or elderly patient with low demand, we recommend a uni compartment. So there are two different groups.
That will be a different debate now.
Yeah,
So
yeah.
we should stick to the joint replacement.
Yeah.
Yeah, Dhanshikar, one question. When you're using these hinges,
Yeah.
what are your criteria for selecting a condylar loading versus an axial loading hinge?
So in the neuropathic arthritis, I use only a condylar loading because they don't do axial loading joints don't do well. So the SROM noise is an example of condylar loading. Neuropathic arthritis where there is a high risk of recurvatum, these axial loading devices are fail early. So these are the main difference between these two implants. So most of the time for post instability following TKR, MCL deficiency or LCL deficiency, we can use a axial loading. For neuropathic type of arthritis, better to go for a condylar loading.
And just one more question, that when you're talking about mid-flexion instability, do you think using a single radius femur makes a difference?
So though we don't have the data about that. So one of the cause for mid-flexion instability was suggested that the condylar design itself, because of the changing radius of curvature, anteriorly the radius of curvature is large. When you go posteriorly, the radius of curvature suddenly drops down. So especially in a PS type of implant where the flexion gap is slightly lax, we can have a mid-flexion laxity. So now they suggested this single radius design to change this radius of design. So, but I don't know whether it has helped because the outcome between the single radius and standard PS is the same. There are no big difference. The RCTs do not show any major difference. I don't know whether it has addressed this mid-flexion instability.
So I think if we are running out of time already, so further questions can be asked later on, and we should go ahead with the next talk. Dr. L. Tomar, sir, please.
Afternoon, everyone. So we heard a lot about the balancing and the bone tissue management. This is entirely a different case. And I will share my experience of dealing with a rare metabolic disorder, that is achondrotic arthropathy, and doing bilateral TKR in this case. So the brief summary about this case is a 65-year-old male, progressive bilateral knee arthritis for last 4 years, bilateral knee effusions with crepitus, range between 10 degrees to 80 degrees of flexion, varus alignment of both knees, history of intraarticular injections, and patient not responding to usual conservative trial treatment, and patient was almost wheelchair bound for 3 months. These were the x-rays. Bilateral knee severe degenerative osteoarthritis with significant joint loss, and the lateral views, again the degenerative arthritis, hip joints, no arthritis, normal hip, except some calcification in the periarticular area, and these were the spine x-rays, intervertebral disc calcification and severe degenerative arthritis of the spine. So primarily it was diagnosed as a case of degenerative bilateral arthritis knee, and we had no idea about this metabolic disorder. So planned for single stage bilateral total knee replacement, patient age is 65 years, and this case was done 7 years back. In 2015 we had done this case. So when we opened the first joint, this was a great surprise. There were all black pigmentation all around, the calcified meniscus, cartilage, and this was the situation. So we had encountered this pathology. We had not encountered this pathology in our past experience of 15 years. This was in 7 years back, and we were not clear about the outcomes. So there was a confusion whether should we do bilateral or unilateral, or should we abandon the procedure. But since we already had opened the joint, so then there were inquiries were sought from the anesthesia, who has 30 years of experience, the other available colleagues in the department, and on phone. So with almost negative response, nobody had the response, but we had come to know that this is a case of alkaptonuria. So the way forward was that we decided to go ahead, and we removed all the black tissue what was available at that, what was present there carefully. We took longer time than usual, and PS design was used, resurfaced the patella as well, and which was put on drains. Then next step was retrospection. So usually we just take care of the 65 years old patient, take care of the x-rays, spine, hips, knee joint, and PAC. Once PAC is cleared, we don't look for other things. So we re-evaluated the patient, history and examination was reviewed, basic tests were conducted, and we planned for the sequential TK after 48 hours of the left side. So the strong positive correlates of alkaptonuria were the hernia surgery in 1985. We had done this in 2015. Renal stone surgeries, PCNL surgery, CVA, which had resolved completely. Laminectomy was done in 2001, cholelithiasis 2004, hypertension, diabetes, CAD, and CBG was done around, say, 10 years back. So these were all strong possible correlations which are present in all these alkaptonuric metabolic disorders. That leads to the involvement of the renal disease and the cardiac disease, also calcification of the valves and vessels. So there were black pinna, the connective tissue were blackened, the black sclera was present, the urine turned black with time, and this urine was positive for homogenetic acid, homogeneticic acid. So then we were aware about the outcomes and about the precautions. We took the next case after 48 hours was sequential total knee arthroplasty with the medial parapatellar extension arthrotomy, blackish discolored all tissue, synovium, all cartilage, all ligaments. It is embedded in the ligaments also. So no normal tissue planes are there as are in autoimmune arthritis. Synovial membrane you easily can dissect, but here this homogeneticic acid myelin pigment is embedded in all the tissues. So synovectomy can't remove the whole tissue, it is not possible, and we have to rely on the bony landmarks and avoid overdoing synovectomy because we can damage the ligaments also, and ligaments in this condition becomes very fragile, and there is chances of injury to the tendons and avulsion of the tendons. So this left knee also we encounter the same blackened femoral patellar and tibial cartilage with chondral loss, cross chondral loss. This chondral loss that we saw perioperatively was not visible, was not evident on x-rays. So removed the thickened cartilage. The meniscus was so hard that it was difficult to remove with the blade. So placement, the another point to which we have to be careful about the patellar tendon avulsion. The patellar tendon and the other ligaments are fragile in this condition because of the accumulation of homogeneous acid in the ligaments as well. This was the tissue that we had removed from the bone and the cartilage and the synovium. The bone outside looks very hard, but when we cut it, the bone from inside is very soft. So we have to be very careful, while taking cuts and while manipulating the bones, where there is risk of perioperative fractures. This ligament, this homogenetic acid is all embedded in the cancellous bone. So we don't need to remove all this the pigment from the bone. Again, this was the immediate post-operative X-rays. You can see the patella also resurfaced, and this was the X-rays on 1 year follow-up. We were not sure whether this will loosen or not, but it didn't lose. There was no loosening at 1 year follow-up. This was the lateral X-rays, and this was the kind of range of movements. The patient had started walking very soon as the normal patient, and patient was without any support walking around 6 weeks time. And this is the patient is walking without support, but there is little balancing in the gait. It is because of the metabolic disorder. It is because of the metabolic disorder which leads to the deficiency of the neuromodulators. The tissue was sent for histopathology that was consistent with the ochronotic arthritis. So what is ochronotic arthritis? It is a metabolic condition that is L-captonuria, and is a very rare autosomal recessive metabolic disease affecting only 1 in 2.5 lakh individuals. Here, homogenetic acid is the intermediary product in the metabolism of phenylalanine, which is an essential amino acid and which is responsible for synthesis of neuromodulator, catecholamine and dopamine. So in the metabolic pathway midway, there is this homogenetic acid is there, and because of the deficiency of this homogenetic acid oxidase, it is not metabolized further. So there is deficiency of the neuromodulators, and there is accumulation of this homogenetic acid in the body, and however this is efficiently excreted through urine, so leading to L-captonuria and urine turns black, and this homogenetic acid polymerizes with the collagen in the connective tissue, leading to ochronosis, that is blackening and other of the tissues, the renal disease, the heart disease, and it gets deposited in the joints, leading to arthritis. So phenylalanine is one of the 9 essential amino acids, and because of this deficiency, the midway product in the metabolism is not converted further, and there is accumulation of homogenetic acid. So the consideration in arthroplasty based on literature are the patellar tendon rupture is quite can happen, and it has been reported, and in any arthroplasty patellar tendon rupture is a disaster. The other ligaments are also stiff and fragile as well. Be careful while taking cuts because the bones are soft, cancellous bones are soft, and there is risk of perioperative fractures, and because of the metabolic disorder, there is excess blood loss. So we have to be careful about that and use tranexamic acid intraarticularly, preoperative and postoperatively. So learning from the case is like every case requires individual attention. Not that all cases are similar, so any case may have the problems. So and it may avoid preoperative surprises. Total knee replacement, however, has excellent outcomes in a patient with significant degenerative arthritis secondary to chronic ochronotic arthropathy, and rare disorder also needs awareness. We got published this case report and with review of literature in a rheumatology journal in 2020. Thank you very much for the kind attention.
Fortunately, this is a very rare disorder, but unfortunately, we are not able to diagnose it preoperatively. Only once I had encountered in fractured neck of femur, where the head was absolutely black, charred. So I went ahead as usual, and fortunately, the patient is all right, behaved as normal as other. So it is always diagnosed after the surgery.
It is
very
yes.
difficult to diagnose it before.
I think if you see the literature, then most of the time it's an intraoperative diagnosis. The second point is that it doesn't really alter your line of treatment very much, except that you have to take care of the osteoporotic bone and the very fragile ligaments. So you can get spontaneous rupture. So that's what you have to be careful about. And I think the outcome is, well, like I said, there's a little bit of ligamentous laxity, I suppose. The only thing is, I do not know if somebody can give an opinion whether you should convert to some sort of constraint in these knees.
Any experience with anybody of
Constraint
Dr.
means
Maheshwari,
like
sir?
PS joint was used in this case. PS joint was used. This is a kind of little constraint. The laxity in the gait is because of the ligamentous nature, and there is because of deficiency of the neuromodulators as well. Because the essential amino acid phenylalanine and tyrosine are responsible for synthesis of the catecholamines and dopamines, which are neuromodulators. And there is deficiency of neuromodulators as well. So the patient had that kind of behavior and that kind of gait because of that also.
No, I think regarding constraint, I don't think there is any role for increased constraint, because the soft tissue balancing, everything like rightly pointed out, you have to be a little more careful because of the deposition of the tissue. But otherwise, constraint, there's no role.
Only when you're doing a shoulder replacement, we opt for a reverse shoulder. That's the only difference. We did a case where did bilateral knee, bilateral hip and shoulder as well, and spine fusion for one patient. We published it also. The shoulder, I think the surgeon used a reverse shoulder. Otherwise, knee, we used only a PS type.
Usually, in the first decade, the spine is the first to be involved in this disease, then the knee joint, then the hip joint, and then later on the shoulder joints are also involved.
Yeah. Because you're worried about progressive cuff arthropathy.
Yes. Okay.
I think with this, this session ends and we are already running late. So I invite the...
Thank you very much.
Sir, Dr. Maheshwari, sir.
As early as possible, so we can do a lot of question answers basically. The more time we get, we can ask more questions, and that will... Yeah.
Dr. K. Tripathi, sir. Dr. Rajesh.
Okay, I think we start the show. So let me invite the first speaker, Dr. Amit Jaiswal. He will tell us about his experience with the TKA in post-septic arthritis. This is a competition paper, so we are supposed to mark.
I would like to thank Prasad sir for inviting me and for giving me the opportunity to speak and to present my case.
हटवा दो यहाँ से. Punctuality is the whatever success.
So, I am presenting a case of a 65-year-old male having pain and mild swelling in his both knee, inability to walk, and had a history of septic arthritis in his left knee 20 years back. Currently, he did not have any raised TLC, DLC. I mean to say that his TLC, DLC, ESR, CRP, and serum procal is normal, and no warmth, no tenderness at the local site on the left side. And these were the X-ray. Patient has a varus on both the sides, type 1 tibial defect on right side, and type 2 defect in both the tibial as well as on the femoral side. Range of motion 0 to 120 degree on right side and 0 to 70 degree on left side. So during the before the surgery, I had a pre-op planning, and I had a lots of questions in my mind before the surgery about the choice of implant. Definitely in the right side, I had decided to go with the conventional implant, whereas in the left side, I have to choose between the semi-constrained or constrained, as there was a type 2 defect on both the sides, femur as well as on tibia. There was a question in my mind that whether I'll be able to manage the bony defect with the sleeve or cone. And third question was a backup of implant, because on the left side only the EP condyles were there and both the femoral condyles were damaged. So during the surgery intraoperatively, there was a risk of damage to the both MCL as well as the LCL. So I had decided to go with the backup implant of hinge knee. Femoral sizing was another issue, because in conventional knee we take the size from the anteroposterior thickness of the distal end of femur, but here we can see in the X-ray that posterior condyle is completely gone. So I had a challenge with the femoral rotation. The only trans-epicondylar axis was the reliable point for us for a correct femoral rotation. And definitely last but not the least, the joint line was another challenge. So I had managed this case with the TC3 insert, sleeves on both the sides and stem on both the sides. And during this surgery, I had a mild hairline crack during the final hammering of the femoral sleeve. So I had managed managed this fracture with the two encirclage wires. This was the post-op X-ray 4 years after. Post-op range of motion. And a surgical video. Cursor is not moving. बट वो चाहिए बहुत इंटरेस्टिंग चाहिए वापस वीडियो में छोड़ो ना इसको मिनिमाइज करो इसको मिनिमाइज करना और वीडियो प्ले करना
अब क्या दिखा रहे हो पोस्ट ऑफ वीडियो
yes yeah I've just I'm going to show last walking video. Last video है बेटा बाहर गया.
How was this patient walking pre-operatively?
Sir, he was having pain and very difficult. He has a difficulty in walking.
Was he using a walker or something?
Two crutches basically. He was using 2 crutches before surgery. This was the 4-year follow-up post-op. I had operated in 2018. This is the video of 2022.
So what is the point you want to highlight when you say post-septic arthritis? Is it one of those bad knees that we do off and on?
Sir,
or anything specific about septic arthritis?
In this particular case, there was nothing specific for septic arthritis because that infection has already been resolved and patient currently did not have any signs of infection. Even I had taken samples during surgeries, 3-4 samples from different sites for histopathology as well as for cultures, but it was non-conclusive. There was no active infection. Since patient has given the history of that, patient had a infection 20 years back and he had a small sinus, healed sinus as well as a scar on the knee. That's why I just emphasized.
I have 2 worries if I think about such a case. One is so much fibrosis inside.
Yeah.
Will I be able to identify my ligaments and capsules properly, number 1? And number 2 is this patient has been walking on a dangling knee like this. How much can I trust the soft tissues?
Yeah.
Like I will have a tendency to go for a hinge in such a knee.
That's why I had a backup implant of hinge knee, and since on table I was able to manage with the TC3 only, and his knee was completely balanced. So I decided to go with the TC3.
Did you operate the left side first or the right side?
Left side first, right side first.
Exactly.
It was a good point because by operating on the right side first, you could at least identify the size, which would go on the left side.
And the limb length equality should also be considered if you operate right side first.
Yours is about 20 years old, 20 years post.
Yes.
How earliest you can go if you are going for this TKR and septic arthritis?
How earlier? Sir, if patient did not have any symptoms, in this case particularly, if patient did not have any symptoms and all the blood parameters are normal, so we can go at any time.
How much is the bottom line for the ESRCRP?
Sorry?
What is the bottom line of ESRCRP, which is, you say that it is infective, it is non-infective?
He's asking for the highest possible level, which you would say, okay, it's non-infection.
Of the normal ESRCRP, I could not understand what you are.
So the question is, if I have a septic arthritis patient today, I treat him with whatever treatment and he's recovering, when do I decide that I can take up this patient for a TKR? That's his question. How do I decide? When do I? 3 months, 6 months, blood parameters?
Yeah, it's not only the blood parameter, or I think I should consider both clinically as well as hematology and as well as radiology, all three. If we are comfortable that all clinical symptoms has gone and all blood parameters has come to a normal level, even then we can wait another 3 to 6 months. If patient is mobile, either on crutches or on walker, we can wait.
Okay, one question. Do you think a CT or an MRI done pre-operatively could have added in your planning, and in what way?
Definitely, if you are considering this bony defect, definitely CT scan will definitely help in my pre-operative planning, especially managing bone defects. Yeah, CT scan was done, but unfortunately I have not seen. MRI in this case I didn't.
You think it was better to do an MRI?
I do not find any extra advantage of MRI in this particular case.
Sir?
One step ahead of PET CT and bone scan, or CT MRI will do?
Why PET CT, sir? Why PET CT?
Not for infection, not for infection. He's very clear, he's saying that he needed the CT for bone defects, identification, but not even an MRI to check for the ligament laxity.
Ligament we can assess clinically as well. No?
I think these days with available equipment and implants, these are all intraoperative decisions. I don't care how much bone defect is there because I have all kind of implants. Sir, I don't care what is the condition of the ligament because I have all kind of constraints.
Ligaments we can assess preoperatively as well as intraoperatively, and for bony defect we have all the armamentarium before the surgery. I had TC3, I had
it's all intraoperative decision.
Yeah, so I had rotating knee. So
I think Dr. Amit is very clear. Sorry, I'm speaking. You may have all the CTs so that you have a plan in your mind. But backup gives you the security to deal anything on the table. So both the things are important. You cannot go to the surgery without a plan. So CT was important to know how much defect. So at least in your mind you are operating the patient. So that gives you some idea, yes, what are those possibilities are there, what I'll deal. So definitely septic arthritis, the first and foremost thing we will think of soft tissue problems. How is much
James,
scarring.
would you do a CT scan and an MRI in this patient, James?
Not MRI. MRI don't. For ligaments, it's a clinical.
How about CT?
So I'll approach this case as if it can go left or right. I don't think T-scan, I see enough on the plain X-ray. I'd have a primary, I would have a revision, I would have a sleeve, I would have and I would have a hip. I would waste. I don't think I'm going to get any more information from a CT scan. It's all on the X-ray.
But many times, sir, on plain X-ray, big tibial defects we cannot assess. It is obvious in this case, yeah, but in many cases you may not assess exact defect on plain X-ray, whereas CT scan different sections shows better.
Yeah, matter else. When I have it opened up.
One question, sir, I would like to ask from the seniors. about the joint line. Sir, in this pre-op X-ray, actually that joint line was below the head of the fibula. So I had a question in my mind: if I try to elevate it toward normal level, will I lose the preoperative range of motion, which is already 70 degree? Because all the soft tissues are contracted and they are according to the this artificial joint, and we are going to recreate a new joint which has a higher joint line level.
Amit, I think we'll discuss this over lunch maybe,
sir,
because 10 minutes are over.
One thing, you'll find the meniscal scar. Yeah. Find the meniscal scar and you'll that joint back to where it needs to be. The meniscal scar will still be there. The meniscus will still be there.
Maybe it is there in a septic knee still, maybe not there. So anyway, I think this is a discussion at some other time. So I'll invite Dr. Gaurav Gupta. Thank you very much, Dr. Amit.
Thank you,
and
sir.
He'll talk to us about decision making in periprosthetic fractures.
So good afternoon, everyone. Thank you, Dr. Prasad, for inviting me. And I was not aware this is kind of case presentation session, kind of competitive one. So I have cases for periprosthetic fracture. I have some discussion also.
So you are out of competition then?
No, sir, I have some slides for the discussion also, and then a case presentation. Case is also there. Replacement surgeries are increasing so as the complications, especially the fractures around the replaced joint. Because of the longevity of the patient, the badly done knee replacement, they all predispose a patient to a possible periprosthetic fracture. So in our practice, we all see these fractures very routinely now. As a trauma surgeon also we deal, and as an orthoplasty surgeon also we deal those fractures. The approach is different. Most of the trauma surgeons like to fix them. Now we have better implants available, and the result of the fixation is also good. So we try to fix most of these fractures, but there are times when the fixation is not possible and the results are guarded of the fixation. So we just find the options of replacing them, the revision orthoplasty, especially if the patient is like very elderly, less mobile. So it's good to take a decision of doing a revision. So with this background, I just want to discuss a few points about a periprosthetic fracture. It can happen into tibia, femur or patella. So I am specifically talking about supracondylar periprosthetic femur fractures with some cases. So there are risk factors which predispose a patient to periprosthetic fracture, like rheumatoid arthritis, neurologic disorders, in chronic steroid therapies which a patient is taking for rheumatoid or some other problem, osteoporosis. So all these patients are elderly, geriatric, having osteoporosis, having some medications, and sometimes they are having some neurological problem also, imbalance or decrease motor power in the muscle. With time they become less mobile. Sometimes the walking is not very coordinated. So they have a tendency to fall and having a fracture. Even a minor fall in an osteoporosed patient result in a periprosthetic fracture. There are some risk factors which are surgery related or surgeon related also. We all know that the anterior-femoral notching is a common complication during the primary TKI surgery, and we all try to avoid that. But sometimes we are not able to avoid and do the notching in osteoporous bone, and these patients are very much prone for the supracondylar fracture. In tibia also, wrong component positioning, malrotation. In patella, if we resect too much of the patella and there is a malrotation of the components of the tibia femur, they predispose the patella to the fracture. So goal of the treatment is to get a stable joint and complete fracture healing if we are going to fix that. a decent range of motion we expect, even if we are not able to achieve the complete, the ideal goal of the treatment, we should at least aim to achieve a functionally favorable results. Like patient should have at least 90 degree of knee bending so that he or she can perform his daily routine activities. Shortening should be less than 1 centimeter. There should be not be a severe varus or valgus malangulation. There should not be a torsion if we are fixing the fracture, and there should not be a hyperextension or flexion deformity of the distal fragment. So how we go ahead? So we evaluate the patient first. This is very important. We should take a proper history in the examination. We should know what are the patient demand and why this fracture happened. Was there any problem before the fall? The patient, many times these patients have a problem knee replacement. They have some kind of instability, pain, stiffness. They don't have a normal gait. Then they had a fall. So these things predispose. The problem knee replacement, they ultimately land to you with the history of fall and a fracture. So you should know what kind of fracture you are going to treat. If the knee previously done is giving a problem, then you better plan to revise it rather than fixing it, because you are not going to get good result even the fracture unite well. So this is a very important part to know the pre-fracture, pre-fall ambulatory status of the patient. Then infection need to be ruled out because there's a chance of implant loosening. There are subtle infection also sometimes, not a frank infection that lead to the painful knee joint. And these patients are elderly. They need a proper thorough workup to rule out any other comorbid or other problems and to optimize them. And you need good quality radiograph because you are not able to assess the fracture underneath the component, the implant. So you need different views. You may need a CT scan also, just to have a more idea what kind of fracture you are going to deal, whether you are able to fix it or not. State of the soft tissue is also important because the surgery is going to be more massive, and the neurovascular status you should know about the limb. So with this, there are different classification for periprosthetic supracondylar fracture. It's undisplaced with a stable implant, displaced with a stable implant, or displaced or undisplaced with a loose implant. So the different classification system, I will not go into detail of these. So this is a treatment algorithm. So we try to fix most of the fracture if the implant is stable. If the femoral component design is allowing us to put a nail inside, like an open box design, we prefer to put a nail if we have a good distal fragment. And if there is a closed box design, then mostly we put fix with the plate. And if the implant is loose, then obviously we plan for a revision arthroplasty. So this is a schematic diagram to just show the implant of choice or the treatment of choice depending on the fracture position. If we have a good bone stock distally, preferably a nail is a better option. If we have fracture line very low, then locking plate are good. And if the fracture is going too distal into the implant, then there is a less chance of getting any stable fixation. So better to go to a revision arthroplasty option. So we have different options to fix these fractures. Historically, we had dynamic condylar screws and buttress plates, but nowadays these are not longer used because we have better plates. We have better locking plates with multiple, with even a variable angle option. So most of the time we use those plates only. The many advantages, we can do the minimally invasive, with a minimal dissection, minimum blood supply, with the preservation of blood supply of the fracture. They give us a rigid internal fixation also. We can use cable or wires also over these plates. And we have different angular screws to get purchased anywhere in the bone in the distal fragment, even if the bone is very less. So these plates are being used more commonly nowadays. Nails are also a good option. We have better nail also with multiple locking options distally. So nowadays we can fix these fracture with the nail even if the distal part is osteoporotic and having a less bone stock. So revision arthroplasty is indication if the process you feel the process is loose, is an inadequate bone stock, there is a non-union, then obviously you plan for the revision arthroplasty, but that need a good training and logistic and implant options. So coming to the cases, my first case is a female, 77-year-old. She is a hypertensive, non-diabetic.
Gaurav, just one case.
Sir, very short.
Okay, only one case, right.
So she is living alone and home ambulatory only, not moving much. She used to come to me for regular follow-up. She had a bilateral knee replacement way back in 2011. And since then, she was always having a problem knee. She used to walk with some support and always having some pain or instability while walking. So he used to come to me for regular follow-up every month. And I used to tell him that you may need a revision knee replacement because this knee is having instability and a lot of ligament laxity. And the knee was going in valgus. So I used to counsel him for the revision surgery, and she was just postponing it. So one day she had a minor fall. She even don't remember that what happened. She is just saying that she fumbles, she trembles, and something happened and she fell down. So that was not even a fall. So then after she landed in the ER with the fractured distal femur. So this is her X-rays after the primary knee replacement surgery. They are looking quite okay. Right side, there was some valgus laxity in the knee. There was ligament laxity, and there is a osteoporosis which is evident. Though the implant are looking well fixed. These are the X-ray before she had a fall. So after she had a fall, these are the X-rays. She had a bad supracondylar fracture, very low lying, with osteoporous bone, with comminution, and probably the process is not looking loose in this. CT scan, the CT scan is more horrifying. That there is a lot of combination looking, though there's an implant, so it's not so clear, but it is giving an idea that is going to be difficult to plan for a fixation in this fracture. So still, as nowadays we plan more and more fixation rather than a revision arthroplasty. So I kept both the option ready, thinking that if I could fix it on table, if the implant is stable, then I would like to fix it. I would like to try to fix it. Then I open it. The exposure is important. When you plan for both the things, you may go for a revision, you may go for a fixation. Then you need a good exposure. So this is an extension of the medial periapparator approach only. That you extend it into the plane between the rectus femoris and vastus medialis, and then you divide the vastus intermedius, and then you have access to the whole femoral shaft up to the mid. So that approach I used. Then I assessed for the distal fragment. The femoral component was apparently loose, though there was a lot of combination also. There was multiple bone pieces and there was severe osteoporosis also. With this approach, the extensor, that quadriceps tendon is intact, and we have a good exposure of the whole distal femur. Apparently, tibia is looking stable, but then I decided to go for the revision arthroplasty because I thought that this fracture is not good for fixation. I may not get the good hold. So I removed the component. There was minimal bone with the component, but to my surprise, the tibia came out without having even a cement a particle over it. So that was I was not expecting it. So this is the cement mantle which is lying there so pristine and smooth. So this is a kind of debonding from the tibial base plate. But the patient was working on this for last 10 years. And she had problem. So there was subtle loosening or instability before the getting the fracture. So that are the signs. So I did a revision arthroplasty with LPS system, and with using the stems, both sides.
Result दिखाओ.
Sorry, sir?
Result.
Sorry, sir?
Let's proceed fast. Time ho gaya aapka.
Achieving getting the full range of movement on the table, full extension, full flexion, maintaining the joint line. There was, I retained the patella. Patella was replaced, so that was tracking well over the femur. These are the post-op X-rays, good alignment, maintaining the joint line, putting stem. I had a fracture while pushing the stem into the femur, so which I just tied with a wire, and the stems are sitting well, stable, not abutting the cortex anywhere, cemented stem, and the patient was able to wear weight from the next day, and she was able to walk. And after 2 weeks, when she came for the stitch removal, she is walking with the walker independently and having a good knee flexion. So this is my first case, the second case.
That's okay. That's all right. Thank you. So one comment I want to make is when they fall down just like that, and they were having some complaint in the knee already, suspect that there was some erosion happening behind the femoral component, lysis.
Yes.
They break through the lysis. So it's not a traumatic injury, and there you must very strongly suspect a lysis behind the femoral component and be planned for a revision right from the beginning.
Yes, sir. So before planning for a fixation, you should always be suspicious of having a loosening or a problem knee. And if you know already that patient had problem before, then
even the immediate post-op X-ray of the left side had too much of valgus on the femur. So that means there must have been some problem intraoperatively as well.
Yeah,
If you look
immediate
at
post-op X-ray of after the revision orthoplasty.
The first surgery.
Yes,
the primary
she had a valgus laxity. So she used to walk like this, and she used to hold everything while walking. So she had a problem walking that time also.
Chalo, thank you, Gaurav.
Thanks.
So this is quite an information. And so let's invite next speaker.
Thank you, sir.
Who is this?
You and your lunch. Kindly be here for some time. So.
But your case is good. Severe varus knee.
Yeah, will be more interesting one. Hello. Yeah, perfect. So this is 79-year male having severe varus deformity of the knee with more bone defect on the right side and less on the left side. So midline parapatellar approach, minimal release on the medial side, and this was the X-ray, this was the intraop picture after taking the minimal cut on the femur and the minimal cut on the tibial side. So you can see there, so almost half of the medial condyle from anterior to posterior is completely lost, and this was the vertical defect. And this was after taking the soft tissue. You can see the perfect end-on picture of this. So what are the options I have at this position? I can increase the bone dissection, but this increasing the bone dissection will lead to decrease the quality of your subchondral bone. So that is not very good option in this case. At the same time, the soft tissue sleeve of the implant also get compromised. Next option that very well shown by Maheshwari sir, translation of the component toward the lateral side, resect the medial condyle, what left there. This will decrease the tension on the MCL. So this can be done with defect, minimal defect, like this case. This was having the defect, and this was managed with the translation of the tibial component and resection of the medial condyle. Next option, we have the bone cement that can be done for defect which is almost less than 5 millimeter. Like in this case, the defect was managed with the bone cement. Dr. James will be happy to see the plating on this stress fracture. Next option is the screws, which should be done for the defect which is in between 5 millimeter to the 10 millimeter, like in this case, which was done with managed with the screws, and this was the check X-ray. Next option is the bone graft. That is my favorite one. Next is the metal wedge or maybe augmented tibial component. So all the time I use this bone graft. Advantage of this: preserve the subchondral bone, prevent the possibility of cement fragmentation. This provides the uniform cement thickness at the tibial base plate and also avoid the use of the custom implant, that is the non-living things. But there is associated disadvantage of this, that graft may be limited. Like in this case that I managed with the graft both the sides, but on the right side graft was limited. Next, fitting of graft may be difficult. The incorporation of graft is always unpredictable. Like in this case, this is the 1 year case. So about the technique, most of the time we use the graft taken from the femoral cut. So first make the tibial concave side to a straight one, put the femoral graft, fix with the 2 pins and then fix with the screws. So this was the case that I have initially, the first case. So this was the defect after preparation, making it cut sharp, and this was the graft I have checked for proper fitting, and this was fixed with the 1 screw and 2 and 3 screw, that is away from your prepared tibial part. And this is the tibial tray with the stem is there, and this is the immediate check X-ray. And opposite side was managed with the simple cement only with a stem. Definitely size of a stem should be shorter one. And this is the 1 year follow-up. The graft incorporation is that we have discussed may be unpredictable. But this is the 3 year follow-up. Graft is well incorporated. He is 82 years now. He is doing all his work very well. So take home message, even with such type of severe varus knee, you should release the medial side in a stepway manner, remove all the osteophytes, and osteophytes, particularly those inside the MCL, that is very important. So if you see, this is the osteophytes that is away from the MCL, but ideally this is the osteophytes which is responsible for tinting of the MCL. So the osteophyte that is inside the MCL, that has to be removed along with this osteophyte. So this is the osteophyte that was outside the MCL, and after that removal of this. Yeah, this is the osteophytes, that is the most important osteophytes that will decrease the tension over the MCL. So release this osteophytes, that is more important. And definitely cut should be very conservative, and usually don't resect till the medial side defect, and lateralize the tibial component. Thank you. And I am inviting you all for first Patna hip orthoplasty course, going to be held on 19th and 28th November next month only. Thank you.
Thank you, Arvind. So I think he has highlighted all the points, that you remove all the extra bone, be conservative with your cuts, and have a backup plan of making your implant sit properly. Only comment I would like to make is approach in a young person, 60, 65, even up to 70, is different than approach in a 70 plus. In a young person, you want to preserve the bone. So use a graft, use a stem, but let the body build up rest of the bone also, so that in future he might need revision. Whereas the elderly person, 75-year-old, today I will use augments, maybe sleeve, maybe rod, whatever. We in this society, we are very price conscious. But imagine a 75-year-old person should have only one surgery. Don't trust God. Trust your implants, your instrument, your equipment. It may mean more money. When I put a bone graft, I am depending on bone graft. In a 75, I don't want to depend on bone graft. I want to use rather implants to give me that confidence and stability. So I think there is a difference between when you are operating on somebody 70 minus and 70 plus in terms of implants that you use for stability as well as constraints. An elderly person cannot avoid any, you can't go for a second surgery.
Yeah,
so build up whatever best you can do on the table so that you don't depend on the nature. That's my approach. I don't know. What is your comment on this?
I think for the younger patients, definitely you have to do the, you can bottom line can be apart from 10 millimeters, go up to 12 or 14 millimeters, and unnecessarily avoid the putting the cement or screws. But in the elderly patient, as you said, that it should be reconstruction of the bone.
Well, sir has also already elucidated the concept of trying to preserve bone as much as possible in the young, and I agree with him. So,
That's all right. Thank you. I think the house is open for lunch.
Yeah, thank
no
you.
questions.
We are dispersing for lunch just for 30 minutes.
I'm sure you're hungry for lunch rather than academics now.
It's for 30 minutes, just come back in time, please. It's 2:40.
On the desk, Dr. B.D. Chatterjee, Dr. Sanjeev Jaiswal. Lecture with the case presentation, TKR with path fracture tibia. Dr. Sandeep Kapoor. Next, Dr. Sandeep Gupta. He will be presenting on the proximal tibia replacement in case of osteosarcoma. He's also.
Lunch session, so I'll try to wake all of you up. This is my presentation about defects and laxity, how I take them down. I'll be trying to present 3 different cases. The first case, we can see here the amount of laxity anterior-posterior as well as mediolateral in this particular case with the amount of valgus. This is the second case, again, the third case I'll be taking with a fixed, partially correctable varus deformity. So taking on the first case, this is a 65-year-old male, complained 6 last 15 years, and right more than left knee pain and laxity on bearing weight. This is how the video looks like. We've already seen it. So this is how the this is how his X-ray looks like with a valgus more than 25 degrees. The most important thing in such cases is a correction X-ray. So as soon as we do the correction X-ray, we know that the deformity is correctable. Number 1. Number 2, if we look carefully, we can see a huge defect on the femoral condyle laterally. So we know that pre-operatively we have a bone defect to deal with. We confirmed it with a CT scan, and this is how the knee looked like when we opened it up. There was a huge defect on the lateral condyle posteriorly, and we used the bone cuts to fill it up. This is how we filled it up. I've used a screw from posterior to anteriorly, and I've used a primary system. I could get away with the primary system because I took care of the bone cuts. The bone cuts were bare minimum. I had cut only 5 millimeter of femur and only 4 millimeter of tibia in this case, so that I can get away with the primary knee system in this particular case. This is how the patient walks post-operatively, and he's up and about for the replacement for the another side now. Second case, another female, 60 years, difficulty it's in 10 years, and walker aided homebound female. We have seen the X-ray, we have seen the examination. This is how we operated it. We had taken a cut of around 7 millimeter on the femur. We had taken around 4 millimeter on the tibia, and then the shape of the bone cut was just like this. We did not have a surface to put our tibial plate on. We took extra 2 millimeter cut so that at least we could diminish the medial bone defect, and the posterior part of the lateral tibial condyle was dealt with a screw and bone graft. We added morselized bone graft to it. So in this particular case, we have used the bone chunk as well as the morselized bone graft. While putting the stem, we had a shear fracture of the medial condyle as well. So we have fixed it with two CC screws, and this is how the post-op X-ray looks like. In this particular case also, the point is to be noted that less bone cuts is the first thing which we should follow in such complex cases, because we can always recut. We have to be as much conservative as possible for the bone cuts. Case number 3, this was a varus deformity with recurvatum deformity of the right knee joint. The varus deformity in this case was 27 degrees. This is how the X-ray looks like, and this is how the correction X-ray looks like. In this particular case, after careful assessment, we could see that the defect is too much vertical. It is sclerotic, and in this particular case, we had tried to cut less bone and then used bone graft. But as we went inside, the amount of defect was too much, and then to reduce it down and to balance it properly, we had to use a varus valgus constraint with an augment. So this is how the post-op X-ray looks like in this particular case. So all of these 3 cases had bone defects and laxity, but in all these 3 cases, we used different approaches to deal with different bone defects. So the tips in such complex scenario cases is always cut less, because you can always recut. Pre-op examination to check the laxity is very important. Pre-op assessment of X-rays, especially the correction views, are very important. Dealing with the bone defects, we can use cement with screws, bone grafts, morselized as well as chunks. We have to have metal augments in very severe and sclerotic cases. Stem extensions have to be with us when we are dealing with complex primary knees, and we can also have sleeves as backup, as my sir told. In such cases, we have to always use the best possible implant in the first go. For laxity, we have in such cases we have to have thicker polys in our setup, in our backup, and a TC3 like implant for the backups. Thank you. Thank you, sir. Thank you. Please. Sir, yes, sir. No, sir. In this particular, in both the cases of valgus which I showed, there were huge bone defects. One in the first case, it was on the femur side, and on the second case, it was on the tibial side. So I was already prepared for a PS knee. Yes. The amount of bone defect they had, I had to use a PS knee. Yes, sir. Yes, sir. So all these 3 surgery, I had TC3 in my backup, and in the 3rd surgery, I had sleeves also in my backup. No, sir. None of them. None of them. Because my pre-operatively assessment was able to understand that the ligaments are present, lax but present. And the defect or the laxity was much more due to the bone defect rather than the ligamentous. Could not elicit. No, sir. No neuropathic drug. That I have. In these cases, no. Such lax knee in rheumatoid I checked, so it was not rheumatoid. Yes, sir. No, sir, they were not diabetic. Yes, sir. I have used an augment in this case because the bed was not good for the graft. The shape of the defect was not good for the graft. It was too vertical. The shear forces would not have accepted a graft. That's why I went in for the wedge.
Any questions from audience?
There's only the second case, I think.
The first and second case both. And the one in which you say TC3 did not use stem on the femoral side.
Okay, yeah. TC3, retrospectively, yes, I should have used the stem on the femoral side. Agreed to it. In the first two cases, it was more because of the bone quality as well. To augment the osteoporotic bone, I have used the stems.
Okay, thank you.
The answer is that once you have to put the stem, so you need to detect more than 90 mm.
Yes, sir.
So there will be three zones the proximal and middle and the distal. So upper is sleep, you can do part you can do cone.
And the augment in the wedge. Thank you, sir. Thank you.
So the first presentation was mine, but I switched. तो प्रसाद साहब भी रीजन बता सकते हैं कि ऐसा मैंने क्यों कहा. कपिल कुलशेर साहब कह रहे थे कि ऐसा है कि ऐसी जगह ढूंढो जहां पर नींद ना आए. Now the issue is, and Dr. Maheshwari was asking me during the lunch, is this place in Kanpur or is it in Lucknow? So probably that was just on the lighter note, and we welcome everyone to Lucknow. And 2006, and lot of conferences and workshops we've done together. And the only reason for coming today here was the conference being organized by Dr. Prasad. The day he said I should be here, so I said yes. And it's been long. I have not been too much into academics, but the reason is something else. So I've got newfound passion as well. Just a small So we are into different talks now. It's academics, orthopedics, that's the first love, but it's other things as well. And the newfound passion is something related to coming up with hospitals. Now, 6 years back, we came up with a hospital. It is absolutely not self-boosting, I'm very clear about it. That's for our young colleagues who are coming up, and they should know that we were discussing even with this Dr. Maheshwari that a person should be in corporate or you should be on your own. So this animation is basically on teamwork, and I have been into a team. I have been a team player, and today there's a time that it's the time for being a team builder. So what my suggestion is for people who are in dilemma. We were in a charitable organization for years together, and staying together, we made a private limited company, and 6 years back we came up with a hospital of our own. And it was a 100-bed hospital, and now that is what I'm saying, that is newfound passion is another hospital which is coming up, it's 300 beds. So Lucknow has come up with corporates, Medanta, Apollo, corporates, they are there. But even today, I would suggest my young colleagues, I formed a team very early in life. So this is just a piece of wisdom which you can say, to form a team and work as a team. Alone, you cannot do much, and working for corporates and different institutions, probably that's good, gives you experience. But I would suggest, live your own dream and make life for yourself. So back to my first love. This patient came to me, a 62 years old female. She presented with inability to walk because of stress fracture. And she was advised fixation for this fracture. She came to me for fixation. We did an X-ray, and this is what we found. The patient was operated, and a stemmed implant and a fibular osteotomy. This was done in this patient. So it was a mobile tibia. Probably it must have been a non-union, a long proximal non-union for the tibia. So addressing the fracture as well as the joint together. Another patient, 73 years old female, she came on a wheelchair. Again, stress fracture on one side and osteoarthritis on the other side. She had come for a replacement surgery. So what are the suggestions on the plan of management? I took long on my first part, so I'll just switch to the second slide, how to approach such patients with ununited mobile stress fractures in osteoarthritis. This is what we did. A small incision for osteotomy of the fibula. And initially, that X-ray is not there. Initially, we fixed this fracture with using bicortical screws and a 6-hole plate. Later on, we converted into a unicortical once we were reaming it. In the summary, I'll show what all we did and the steps for the procedure. These are the few slides. And it went off to union in 3 months' time. Now the steps were, we exposed the fibula first, did a fibular osteotomy. The knee was exposed. Temporary stabilization of the tibia using bicortical screws. See what has happened. These two cases I did very recently, and when I was operating, and in the second case I thought, let's take a shortcut. Instead of fixing the tibia with a plate, we tried to hold the tibia and ream it up. Probably we were not able to ream it, it was very unstable. So making the cuts, accurate cuts, was anatomical fixation of the tibia using bicortical screws and the tibial plate. And once this was done and the stemmed implant was being put, we converted into unicortical screws, reamed it up, and then used the stemmed implant. Bone graft they were used from the cuts. This lady was from a village background. You can see the patient walking nicely. Now this is third patient. This is a proximal defect, probably I had seen a few slides earlier. And in this third patient you find that it's a very bizarre looking X-rays, and we get to see these X-rays quite frequently. And the moment you see this X-ray, you are thinking that what to do. Let us have a constrained implant. Those diffuse users, they say, let's have a TC3, and whatever different sort of implants, your mind starts going around what all to do. But the first and foremost thing would be a proper pre-operative evaluation. So now with the first X-ray and this X-ray, your things, they change once you give a valgus stress and you find that the X-ray is quite simple, and probably you may not be needing constraints for that, too much of constraints. And the clinical examination, it was basically, sorry, it's not working. So it was a correctable deformity. And this is what we did. And so initially when I had planned for this patient with such a big defect on the medial side, I had thought it's going to be an extensive posteromedial release going to the back of the tibia, maybe a medial sliding distal femoral osteotomy and getting a constrained implant so as to manage this defect. But probably we ended up managing it in a very simple way. Thank you. Thank you for your attention.
Second presentation, Dr. Sandeep, excellent. So there is any question regarding similar article?
So, this is a fairly common scenario in our country where people carry on with the arthritis knee, but when they develop a stress fracture, then it's excessively painful and then they want to come and get operated. Now, one very important factor is how far the fracture is from the joint line. And the rotatory instability depends to a large extent on that. And the further you are away from the joint, the more difficult it is to control rotation with just the fluid stem.
Agreed.
To have a different plate. So in your series of cases, how many times do you actually need to put a molded plate and just give rotation instability?
So as far as the cases which I have done, I've been lucky not to get cases where I didn't get rotational stability. But I agree with your point. One has to be prepared that you have to keep the plate handy. You may use the stem and augment it with a plate. That's fair enough.
If the fracture is above the physical velocity, very seldom you need an additional plate support. The other thing is that the severe observable commonly is not very common in people. Most of the time, we get a fairly a construct. And the other thing what we did was that it's a good idea to use the tips of bone cuts to draft the fracture. That you do not need to put a plate. That's why I think one of the things is actually live. If you, especially if you're doing a similar operation, you've got an unstable stress factor. And you're making it more unstable by touching it. And then you're not supplementing anything with the plate. So I think that is where I would have a slightly different opinion from you, because if you are doing a similar operation, then definitely you will need to along with your stem. It's just like a non-union of the proximity attack. What do you normally do? If you've got a non-union there, you put in a nail and you put in an additional plate. Now you've got a nail in the shape of your figure, right? But then you haven't got a plate. So what happens is that when you are building a figure, it actually allows for a plate. In addition, you've got the figure, which now is further introduced. That is
So, opinion from the learned people from the audience, what Dr. Rastogi is suggesting. So the point is to use, if you do a fibular osteotomy, put a stemmed implant on the tibia, and to avoid rotational instability, what Dr. Rastogi is suggesting, that it's wise to augment it with a plate along with the stem. So one should do it as a rule, or
So I showed you an X-ray earlier whereby I had a periprosthetic fracture, and I always have a distal femur. I will always put a plate on it because I think that you need to control the rotation.
For the tibial stem as well.
Yeah. You don't have. If it's a pure transverse fracture, you may get away with it. No fracture has some up. I think it takes 10 minutes to put a plate on.
So you can come here.
I think it takes 10 minutes to put a plate on. It is no big deal. You're doing a major case. You're there, you have it opened up anyway. It takes 10 minutes to put a plate on. It does not do any harm. It can only do good. So for me, I will always put a plate on. I would use unicortical plate, locking screws with a unicortical plate, and I would put it on, and I would get 6-8 holes, 3 on either side. It doesn't have to be massive, but for the sake of 10 minutes.
I mean, what is your view about this electricity or taking? What is your view?
If it is a uniting fracture, if it is already having some callus, but if it is I think I echo what Dr. Harty said. I think a plate is must because it doesn't add if you're worried about the length of your incision or you're worried about that, I don't think that's a concern. Your primary thing is rotational stability, and I think that's, and you can confidently ask the patient to weight bear also.
So I must admit that I don't do it like that. The reason is there is enough soft tissue and callus which gives reasonable effect. It's a on the table decision. So I would say in my practice, out of 10 times, 2 times I would plate, 8 times it is such a strong callus there already that there is no rotational instability there on the, if you don't open the fracture. I don't know why you did the fibulectomy in the first place. Very often you can just correct it, just like that. It's a little bit of a mobile. So 8 out of 10 times there is enough rotational stability that I didn't think the need for a plate, and I have had no bad results because of that. But I agree, if you're doubtful, if there's a mobility, fix it.
So that brings you back to the question of should you debride the fracture before you start doing the procedure? Because if you just correct it and it hasn't healed, it's a non-union, and you say, well, I'll just treat this as a non-union. If you had a non-union in the tibia and you were not doing a knee replacement, you would not just correct it and put a plate on. You would debride the fracture, you would put it back into correct position, and you would fix it. So I think the simple principles of fracture fixation apply in the same way to knee replacements in these cases as they do to anything else. So I think you take a risk. I don't see any downside to adding the plate for 10 minutes, and you apply simple fracture fixation mechanics to these, and that's how you get it to fix.
I think maybe another different experience I would like to share. If there is a malunion of say 15-20 degrees, what you can do is when you're putting a rod inside, you can open up the fracture, do an osteotomy, get the rod across. I don't do it that way. I just take multiple drill holes at the side of the fracture and just do osteoclasis. And my rod goes in. So basically I don't touch. So this stress fracture is different. You have to stabilize it, it heals. It is different from a routine fracture where non-union, you have to open up everything. Here it is asking for stabilization. So I don't even open to correct malunion, forget about non-union. I just make multiple drill holes, just correct it good enough that my rod can pass in. And because everything is stable, it just heals up. I mean, not one case, maybe 8 or 10 cases like that. So I think hypertrophic non-union or so-called hypertrophic, not a mobile non-union, is what happens most of the time. And if you just stabilize it with a rod, it works. If on the table I find it is not okay, I will definitely put it.
Right, sir. Thank you.
Can I just come back on one more point on this? My problem with not putting a plate on is you now have a revision component in, and you have a stem in, and if that has not united, and it goes on to a non-union, even in that 2 cases, now you have a huge problem. Now it's an even bigger problem, because now it's non-union in 2 cases. If you did 10 and 2 don't unite, you still have to revise 2 cases. You have to revise the whole component, as well as then go and fix the fracture. So for the sake of 10 minutes, for 2 cases, but even for me, for 2 cases, that's enough, because they're huge. When you go back to do that case, it's the worst case in the world. Why didn't I fix it?
The other thing is that most of these patients are significantly osteoporotic. So I think you need to work upon that and treat the osteoporosis.
So the consensus is that the tubular arthroplasty is not related to self-casting. If you are using long stem and if you do the arthroplasty of the tubula, then you must make it right.
Fibular osteotomy may be needed if the reduction is not possible. That's the only condition when you have to do it.
Thank you, Dr. Sandeep. Thank you. Excellent presentation. Next speaker is
Wide awake, and we are awaiting a good talk by Dr. Sanjay Agarwala sir. And for this session, I invite to chair the session Dr. Ashish Kumar sir, Dr. Umen sir, and Dr. Amit Jaiswal.
Great. Good afternoon, ladies and gentlemen. Thank you for this invitation, Amal. I've been coming for the Kanpur course for many, many years. And of course, I couldn't come for the course when you had COVID. No one could even leave home. I need to escape this to get my presentation. Could someone come and put up my presentation? To escape that. So look at Asia and Africa, and I said that's 78% of the world's population. These are our requirements. Does anyone say no to this? But all literature will tell us that this is not possible. You look at Western culture, they like to sit, they like to kneel, and if they are Catholics, they don't like to kneel. They use things like this, yes, but if they go and play golf, they need to be able to pick up their ball and play their game of golf. Placement, and there it is. Let me see if I can get him back. There we are, without that. Now he's kneeling. He's sitting on a stool, a really low stool. Can he sit on the floor? Well, that's him sitting on the floor. That was his pre-op X-ray. That's his post-op X-ray. I have not used a BHR. I have not used a constrained hip. I have not used metal on metal. But I have this gentleman walking like this, and this is what I do for all my patients for the last 20 years. It's published. It's there in the realms of published data. There's yet another patient. He too, with 2 hips, is able to do this. And if you look at the implants, and these are standard implants. This particular one is Smith & Nephew. It's got a dome, it's got 2 screws to hold it in place after I've done the appropriate reaming. But I've used a long posterior wall, and there's a technique. If you don't know this technique, then don't try to do this because your patient will dislocate. So I'm going to show you my secrets. And we published this, as I said, in the CAWNPORE journal in 2021, functional outcome following a large head, total hip arthroplasty, and so on and so forth. We published Restoring the Natural Hip Movement with Large Head, Ceramic on Ceramic, experience of 150 patients. No one believed me, and major journals were reluctant. And like I said, these are the common notions after replacement surgeries. Mayo Clinic. And my list of contraindications after replacement surgery are none. So there has to be some magic, there has to be a secret to this. How is this even possible? Well, this is the way this kind of thing happens. It's magic, or is it the trick? Let me show you the trick of the magic. So here we have a hip replacement that I'm doing. The patient is in a lateral position. Taken a standard incision, I go anteriorly, almost like Harding, but I stand in front. Some of you who've attended the earlier courses, I've done these as demo operations. So you go through the lateral side, you go an anterolateral inside, you dislocate the head, and you can see this head definitely needed a hip replacement. I mark what I think is going to be the cut, measure the distance so that I can replicate it after surgery. So I know that's the center of the head, and that doesn't necessarily match entirely, but it matches pretty well. I take a cut in the neck, and I can now see the acetabulum. You can see the entire acetabulum. I use a Charnley Steinman pin if required. You can use an ordinary Steinman pin. So your assistants are not getting tired during the surgery. We do an incremental increase in the size of the reaming like any of us would, any kind of hip replacement. Ultimately, once you have done the incremental, you take a suitable smaller size acetabular trial so that you know what angles will fit. Then you get the right side acetabular trial. So if you've done a 52 ream, you take a 52. You pack it in and check whether it is nice and tight. You can open out the mouth a little more if you want, so that the mouth is open. Then having confirmed that that is how it fits in, you take your acetabular cup bang it in so that it's really solid, so solid that the pelvis shakes and moves. When you move it, you dismantle the rod holding it, and I don't know why this is stuck. You put your screws in, you ream. These are called, you get them in various sizes, of course, as you know. It's like telling Granny to suck eggs. You do a trial. I put a little loop around my head neck. I put a trial head. I measure. If I measure and it sort of feels right, it's going to probably be right. I push it in. Check that I have the correct coverage with the long posterior wall. I do a telescoping, do a full flexion, do an internal rotation and an external rotation. Check that nothing's getting caught with an artery clip because you've used a long posterior wall. You don't want it to dislocate. Then I drop the leg. If I drop the leg and it hasn't dislocated, then I know I've done a good job. Then we go on to complete the job by putting the liners. Is that stuck again? Well, in any case, what I'm trying to tell you is
okay, start. That's the right way to do it.
So the armamentarium that you have for increased mobility in THR is of course a dual mobility hip, which if you haven't been using, I think this is something that you should have. I've not done a bipolar for many years. I use a dual mobility hip all the time. Freely available, Evolutus has it, Stryker has it. Of course Stryker is more expensive. Evolutus is the right price. And this is the way it works. Patients can sit and squat after surgery. You can use large heads, ceramic and ceramic, and as you're aware that we did have the large ceramic and ceramic cup with the pre-assembled liner. Delta Motion, company's taken it off. There's probably a reason for it. They haven't told us why. We have elevated lip liners. This is what I use all the time. Not a substitute for good implant positioning. You've got to get it right. If you don't get it right, you can't drop your leg across the table, then it is going to dislocate. But primary hip arthroplasty, this is what we have described in one of the journals, using these large delta motion hips which are no longer available. This is what used to happen to these patients who had fractures. They could do all this, they can do all this. This is a patient who you may have seen on ZTV. He's a dancer. Of course I treat him for his avian with bisphosphonates. I'm going to talk about this tomorrow. Patients who don't need surgery, but when they do need surgery, this is what I do, like I showed you. I showed you how I do it. Now you look at this gentleman, he is dancing very well, he's dancing like he should, like a dancer. And at the end, he's going to sit down on the floor, just to prove a point. Oh well, it's going to take a really long time to sit down on the floor. So, my God, this is a fact, this is the way I do it. This is the way I've been doing it for the last 20 years. For increased mobility in TKR, all companies will offer you this if you ask for it. Whether it's Smith & Nephew or whatever, they'll give you a high flex poly, they'll give you a constrained poly. Merrill makes a high flex, Stryker makes a high flex, Zimmer makes a high flex. In fact, Dr. Ranavat was a high flex, but he stopped talking to me after I put this in press in the Journal of Arthroplasty, and the company has since withdrawn this from the market. But with my standard techniques, using any of these high flex knees, I get my patient to sit cross-legged. I get them to walk the same day after surgery. That's pre-op. You can see that there is a deformity, and you've heard about how deformity corrections are weeks later sitting, month later sitting and crossing the legs. Please know, this is what we X-ray, and I'd say we're going to sit on the stool, and then he sits on the floor after a knee replacement. He decided he's going to walk, I think. He decided he's going to walk. So I was given 15 minutes, and I think I've done well. Amal, the secrets of performing this magic is in your hands. You need to learn it, and you need to offer this to your patients. Thank you. 20 minutes short of 15 minutes. Did I get the message across, guys? Any questions? You know, this is an oration. After an oration, you don't ask questions. But do you have any questions here? Come to the mic so everyone can hear.
In your bilateral hip cases, there was a screw where passing through the medial side, it should pass to the posterior superior screws.
Depending on how you rotate it, depending on how much volume of space you have to put your screws. So you have 3 holes, of which you use 2 generally. You can use a third if you're not confident. And you get that in that cone because you don't want to hit the side. You don't want to go and hit your arteries in the pelvis.
And the case was of very early avian. That was the case was changed.
We have. If you've read my papers, I have 15 papers on avian. JBJ's Journal of Arthroplasty, we're talking about all kinds of things. So we've described when you need to be doing surgery in early cases, and if you all are there tomorrow, you will learn how to not operate cases. Not operate them. AVN can be treated medically. That's something that you will need to know. And you all know that it's bisphosphonates, but bisphosphonates that you give for osteoporosis are being repurposed for this. It's not the same dose. If you use chloroquine, you know that for malaria you use 4 stat, 2 after 6 hours, 1 BD for 3 days. But if you use chloroquine for rheumatoid arthritis, it's not the same dose. So, if you think that if you know that you've heard me say about bisphosphonates, and then you can avoid surgery, you cannot. You have to use the bisphosphonates in the doses I've described. I've worked on this for 20 years. You have a question?
Always a fantastic presentation. Just do you actually also inform the patient that there is a possibility that the longevity of these processes may be less? Because that's something that we are afraid of.
Are you really afraid of that? I mean, if you are looking at a very last...
Younger patients, AVN, definitely.
So you're talking of AVN?
AVN, hips. AVN and hips, not knees, because they're not hardly going to do it.
AVNs are operated.
Yeah.
Once you remove the avascular part and you've done the right job, you've got good bleeding bone, these are going to last for the period of time that they're supposed to last. If you use materials of ceramic or oxynium, and it's against a very high, ultra high density, highly caustic polyethylene, it will last. Sorry to hold you up.
One question on...
I like the sound of your voice.
Just one question on the deep flexing knees.
Yes.
Any tips on how you manage the posterior offset? Because I think that's what plays the major role in
It's there in each design, it's different. You can have tucked dish things. You can have the high flex designs of Smith & Nephew. Stryker makes the high flex. I mean, they want me to change what I'm using to that, and they show me that there's high flex. Merrill is high flex. Like I said, Louis Synfix, they are the high flex design of the RPF. Because I showed that you get patella clonus. Not probably in the femur and the tibia, but in the patella.
The post, I think, was too much behind.
Whatever. So,
Even attune allows sitting cross-legged easily. So even attune allows.
Can you venture to give deep flexion with a normal implant, not a high flexing
I think it will not be advisable because we are scared of damaging the posterior part of the poly. That's all. Because when they are sitting up, that creates a lot of stresses at the posterior part of the poly. Yeah, I do agree. But we don't know till we practice it. So that's another part of the story. So friends, that was an interesting talk, and this another talk from Professor James Harty, which has been kept intentionally. This is something which I wanted to talk, but once he suggested, I thought, yes, why not? Because if after this we are going to have a robotic talk. So what is robotic arm? You will see that. But why you see, our brain is like a biggest computer, and our hands are in our control. So our arms are better robotic arms if we want to use it in that way. So I think let it be open-minded. You listen to his talk and then the robotic talk, and then we'll have discussion later on what suits you better. Okay. Enjoy the talk.
Can we go? It wanted to leave Dr. Sanjay up there for longer. It's much more important. So thank you for this invitation. I wanted to kind of introduce to you some concepts that I've been doing for the last 2 years. And everybody in the world now is talking about robots and navigation. But Ireland is a country where I can't get a robot that easily. It doesn't come to me because we have a small population. We'll probably be the last ones to get it. So I have to teach myself how to do a knee in a more modern alignment using standard instrumentation. So this is really what my talk is about how I achieve alignment with these talks. So it's first important for us to understand the different types of terminology. You'll hear people talk about mechanical axis, you'll hear people talk about kinematic axis, inverse kinematic, anatomic, and functional. And there's subtle differences in all of these, and if you don't understand what they are, you will start to not understand what you're trying to do. But in essence, what I'm trying to do is I'm trying to do a combination of inverse kinematic and functional. We know that mechanical axis has been around since time immemorial, but we also know that if you keep putting knees in mechanical axis, you're going to have a certain percentage of patients who are unhappy. 15 to 20% of patients, no matter what you do, no matter how well you put that knee in, no matter how careful you are, they're going to be unhappy. And that's because you're changing that patient's alignment. You're making them go from what they were normally growing up with to what they are now, and they're not happy with this. We know that if you put in a mechanical axis component, you will start to change the alignment of the joint. You'll take different sized chunks off each side. You'll change the flexion extension. You'll change the varus valgus gaps. So a lot of this started with Johan Bellemans when he talked about a certain percentage of people having a varus alignment in their tibia. So about 32% of men have a constitutional varus alignment, and about 17% of women have a constitutional varus alignment. There's a really nice paper that came from Michael Hirschman looking at patients who had non-arthritic knees and looking at CT scans of all these patients. And you can see that there's a strong association with the variation in alignment in these patients. There's a lot of patients have a normal variation in alignment. We are not all mechanically aligned patients. Similarly, in the patient who has an arthritic knee, and if you compare them to the non-arthritic knee, there's very little difference in their overall alignment. They don't change very much. And again, Michael looked at the CT scans in these patients, and when a patient, apart from the severe deformities that you're showing in these cases you've been showing earlier, the vast majority of normally arthritic knees who don't go to these severe deformities end up with alignment which is very close to what they were when they were younger. Go. Oh, my apologies. Go back. The computer is just deciding to go a bit slower. Okay, so you can look at 3D reconstructions in all these patients, and you look at the joint line orientations, and again you can see that they're all very similar when you look at 3D reconstructed images. This paper for me is the paper that really made a lot of sense to me. This is Sam McDesie's paper from Australia, and in it he took a lot of patients that he had done robotics and navigation on, and he looked at all the scans, and he looked at all the preoperative deformities and the postoperative deformities in these patients in the hospitals.
when they were being operated on. And he classified these into 9 different types. He talks about varus, neutral, and valgus. So you can have a varus knee, which is apex inferior. You can have a varus knee, which is apex neutral, or you can have a varus knee with apex superior. So essentially the joint line goes in 3 different directions, and you can have varus, neutral, or valgus. And once you understand that classification, it's very easy then when you come to do these cases as to how to do it. He furthermore worked out how many percentage of patients are in different areas. So the vast majority of patients are varus with apex inferior. So the bulk of patients are what you see here, and anywhere in the world is what you see as apex inferior or neutral. Extremely rare to see a patient with an apex superior varus or valgus deformity. I have seen one. So if you then go and look at how you do this, the same guys went and looked at balancing these knees with the controlling for the soft tissue and looking at restricted kinematic protocol. So by restricted kinematic protocol, they say they're putting the knee not quite exactly to the amount of varus that the knee is preoperatively, but within restricted variables. So 5 degrees of varus, very rarely going more than that, and a tibia in a valgus knee is going in neutral. They don't put valgus knees in valgus on the tibial side. And again, looking at functional alignment, which is a combination of inverse kinematic and balancing, you can again get similar outcomes using sensor-guided technology. So what I tried to do when I knew all this information was I said, okay, well, how do I do this? So all my patients get pre-op long leg views. All my patients have their varus and valgus alignment measured. I measure out the medial proximal tibial angle. I measure out the lateral distal femoral angle. I do standard medial parapatellar approach with a very limited medial release, the same as everybody else. And then I assess my patient for their articular defects. I see where that defect is, and I see what I have to correct. I do the same as everybody else. I remove my osteophytes. Before I start anywhere on the knee, I do all of the standard work. But for me, once I've done all this, then I've decided what I want. The first thing that's critical for me is where I put my femoral hole, because this is the first point at which you dictate how that operation is going to go. And if you place your femoral hole incorrectly, you are going to be sure that you're going to do the wrong operation, and it's going to malalign. You can see I don't open it up to the secondary diameter, and you never see me widening up the space to make it easy. So that femoral hole is exactly the size of the drill that I drilled, and you'll see here that that femoral hole is exactly the size of the rod that I put in. And when I put the rod in here, you'll see I do not get any movement. It is very difficult to put in. The rod is pushed up in the standard fashion. I do not push it up all the way. I don't shove that rod all the way along the entire femur, because I know that's going to push my femur into extension. And then I want to assess where I'm putting my components. So when you put the IM hole in, what's the problem? We want to minimize how far you put the rod in, because if you shove it all the way up, it's going to go into flexion. You can minimize, if you have a long rod, it can minimize your errors in that you tend to be pushed in one direction and it stays there. But actually that alignment may change the alignment of that patient because it doesn't fit with what that patient's normal joint line is doing. We need to get the correct entry point. We need to avoid over putting it into a valgus entry, and we need to avoid flexion or extension problems. So what about the entry point? So there are 2 key points to the entry point. It's mediolateral, to make sure that it's correctly along Whiteside's line, and it's an AP placement, which is just about 10 millimeters above the anterior of the femoral notch after the notchplasty. So this is where you should be putting your femoral hole. You can see where your PCL inserts. You should not be putting it up through the notch, and you should not be putting it in higher than that, because if you make this mistake, and it is the simplest mistake that surgeons make when they start the operation, it is at this very point that they start to make a mistake and they don't think about it. You can see when you put the femoral rod in, if you work it up along the center of the femur, it's fine. And then you can correct where your varus valgus is according to this. And this varus valgus in the distal femur is substantially different in different patients, in the same way as the tibial varus valgus is different. So a 5-degree or a 6-degree cut is not the same for every patient. It changes per patient, and you need to change that for each patient. The drill will go up that, but the surgeon can put the drill in varus, or the surgeon can put the drill in valgus. And then if you set it for that 5 degrees cut, you're going to cut that femur or that tibia different to what you can do, and you can have a strong variation in what that is. So Measuring the angle and understanding what the distal femoral angle was before and putting in the rod is critically important in these patients. Okay? The shaft just acts as a guide. Here you can see an example of how a rod in the same patient is put up in two different angles. And if you set up your rod and your cutting block at a fixed varus or valgus angle, you're going to make a mistake in how you cut that patient. And so the entry point is the most critical point at which the patient starts, the surgery starts. Same drill, same entry point. Neither are extracortical, but there's a 15 degrees difference in how you put that rod in. Okay. So, it's very. I use the attuned knee, and the attuned knee allows me the variation to be able to change my varus valgus angle on my cutting block up to 9 degrees when I want. And then I'm able to change this to whatever angle I want, depending on what the rod is. So I don't look at a number, I look at that, make sure my cutting block is cutting for the varus valgus angle of the femur, and I'm looking to incorporate and account for the deformities and the bone deficiencies that I have. So you can take the block off, and then you can take it off, and then you can see whether you're contacted on the femur or not. And you can use little tricks to make sure that you've got the joint line set back where it is. Because the biggest mistake surgeons make when they do their femur, without realizing it, they proximalize their joint line and they change their varus valgus angle. So you can see here, I've got a simple knife, and I've measured the thickness of the knife. And the thickness of the knife is approximately equal to what the thickness of the articular cartilage is. So I put the knife down underneath, I account for my articular cartilage, I get contact on the medial side, I get contact on the lateral side, and I change my varus valgus angle to correct that knee so that I cut it exactly as I want. I've been speaking to the company asking them to get shims to connect onto the block that would make life much easier. They haven't done that for me yet, but I'm finding little tips and tricks on my operating table. The knives are always the same, I can work something out. You can set the knob to two different angles. I tend to do a conservative distal femur cut first. I never cut 9 millimeters to start, because you can be sure if I've cut 9 millimeters on the femur to start, I will make a mistake and I have no way of getting out of it. So I tend to set the knob for 5 millimeter cut to start. I do a conservative distal femoral cut in the standard LCS pattern that was done before. You can do a 9 millimeter cut, but I wouldn't recommend it. So here you are, you can see me putting a femur in here. I'm making sure that I can see that I've got contact on one side, contact on the other side. I can see that I've set for a 5 millimeter cut. I've set my varus valgus angle for, in this case, I think it's about a 6 or 7 degrees, or even more. Sorry, I'm on 4 degrees on this one, because this is what this patient needs. I then pin it in place, and I cut my femur as I want to cut. And you can see I've accounted for the femoral deformities and I cut it. It's very important when you use this, when you cut with your saw, the vast majority of saws have got a little bit of bend in them. And so you need to be sure that you're cutting this, and you need to run the saw down 2 or 3 times to make sure that you're accounting for the for the fact that the saw displaces. I don't take my pins out. I've really only done a conservative femoral cut. You can see that the femoral hole that I put in originally is untouched. So my reference point for my next cut, if I have to do it, is unchanged. And this is how I'm trying to navigate, because I know where my starting point is and I know where my next point is. I'm navigating from its original position. I always measure what I take off. So I know that I've taken 5 millimeters on the lateral side. I know I've taken 5 millimeters on the medial side when I account for my deformities in this case. So I know what I've taken off, I know where my joint line is, and I know how much I have to go from here. Here's just a lovely paper showing what the surgeons who navigate do. They purposely try to distalize the joint line where the defect is. And this is what I'm trying to do. I'm trying to navigate myself to make sure I don't proximalize my joint line. The next step for me, once I've done this, is to cut my tibia. And I use, again, the attuned jig. And you can see how I can change the attuned jig into varus or valgus to get a different degree of correction. So I can correct, in a small patient, up to 3.7 degrees of varus, in a large male, about to 2.3. And I know that when I do that, this can help. Setting up the tibial jig is a critical part of this. You can see I'm setting up the jig like standard. I use the stylus, and I put the stylus where I think the defect is. If it's a varus knee, I set it on 9 on the lateral side. I then pin it in a central point, and I make sure that that central point is exactly along the axis of the knee. You'll see here that I'm looking along to see that I've got the central axis of the tibia along the central axis of the knee, and I then use a second stylus because I'm trying to make sure that I cut the exact amount that I want on the medial side.
because it's on the medial side. When I do this, I'll get it to match with what I did on the femoral side. I won't have to do any releases, and I will get this knee to do exactly what I want. So you can see in this case, I've got the femur on the lateral, tibia on the lateral side at 9. I've set it on 7 millimeters for 2 millimeters of articular cross on the medial side. I've got the jig sitting where I want it to sit. I've got my 7 degrees of cut. I lock it in position, and I just change my varus valgus angle until I've got contact on the stylus on both sides. So now I'm just tilting that tray exactly as much as I want that tray to tilt. I then pin it in position, and then I cut. So I do the standard cuts the same as everybody else. Sometimes you'll get major deformities. So this is a patient who's got a severe amount of varus. I put my jig on, and I'm getting 9 on one side, and by the time I've done it and I've put in as much varus as I can, I'm only getting 1 on the other side. So I know, and even on this patient's pre-op x-ray, he doesn't have bone loss. So I know straight away I'm not getting that tibia to go in as much as I need to go. So for these cases, I will tend to use a 2-degree offset cutting block. This is the old LCS cutting block. You can see I've done my first cut as far as I can go, and you can see I've not resected enough tibia in this patient. And you can see I've still got this sclerotic bone on the medial side, so you know that you haven't cut enough bone. You've got this large, hard sclerotic bone, and you know that this isn't going to cut enough of that tibia to get it into varus. So I use a 2-degree cutting block, and you can see on the 2-degree cutting block, I'm not going to cut anything on the lateral side. I'm going to take 2 more degrees on the medial side, and I will bring that patient out to about 4.5 degrees of varus once I've done it. Typically, once I've done my conservative cuts, I will then go and check my balancing. I leave my pins in, I don't take them out. I've taken the shim off the cutting block because I know that's 4 millimeters thick, and I then check to see, do I have any laxity on the medial side or on the lateral side? I will typically go through 2 or 3 sizes of poly because sometimes different patients have different degrees of stability. So I started with a 5. I'm now going to put a 6 millimeter poly in. I clip that on, and I don't have my other shim on. And once I put in the 6, this patient immediately becomes stable. So I just needed 1 more millipoly, and I'm checking my varus valgus degree of correction in extension, and it's a stable knee. As soon as I've done this, then as far as I'm concerned, pretty much the operation is over. I then simply have to go back and cut 4 more millimeters on the femur, which is what I do. This is the 2-degree varus cutting block as I was showing you, sorry. Now I have to go back on the femur. The block here is 4 millimeters. I just simply move the block back 2 blocks because each one is 2 millimeters. I recut my femur, and my extension gap is now perfect. Once I've done that, here you go, I'm recutting. Down she goes, standard like everybody else, and then I go back, and just to be sure, I recheck. I then spin my, I've got complete stability in flexion and extension, and then I rotate my block because I want to make sure that I'm not tight on the medial side or not tight on the lateral side. Okay, so then for me, once I've this done, the rest is very simple because I now use everything, I do everything in balancing. I know open up the rest of the femur. I know that my varus valgus is correct, and I use a balance sizer to get these knees because from here on in, I don't really have to think because now I'm automatically tensioning the ligaments in exactly the same manner as you would have with an LCS knee prior to this. I put in the balance sizer, and I then dial it up to where I want it to get. I know the size of my poly, and I'm able to get it to sit exactly where I want to go. Then pin that and cut my block as I want to cut it. Once I put my block on, I can then, before I even commit to shaving everything off, I go back and I measure my trochlea, see how much bone I'm taking off my trochlea. I can put the stylus on the back. I can measure my posterior femoral condyle. I know exactly how much bone I'm taking off my posterior femoral condyle, and similarly on the medial and lateral side. So I know before I complete any of my extension cuts or the remainder of my cuts what I'm taking out of that knee. So then I go back. Once I've done my cuts, I put on my trials. The knee is brought out into extension. And then we check it for balancing. I use a rotating platform knee, so there's a lot of congruity in a rotating platform knee, that much more so than you have in a fixed bearing knee. So I've got a lot of stability in that knee. So you can see the knee is easily coming out into extension. I got a very stable knee in extension. I'll then flip the patella over, take the poly out, and you watch, very stable knee. Flip the patella over, check my stability. When I do this, I'm looking to see that I don't have any change in my flexion gaps or that one of the components isn't lifting and tilting. And I'll show you that in a minute. But if I do this without touching the patella tracks perfectly every time. And the key for me to a happy knee is to put that knee in exactly the correct varus or valgus angle that gets that patella to track exactly as you want that patella to track. I mark my tibial rotation, and then I prepare my tibial tray. So you can see the accuracy of the cuts is critical, because if you're not very careful about how you put your cuts on, the component won't sit where you want it to sit when you finish up. This is just an example of what I will do then if I'm not happy. So again, here I have the patient fully balanced in extension. When I come along then and go and bring this knee up into flexion, I'm seeing a slight tightness when I get beyond 90 degrees. So I'm at 90 degrees, but as soon as I go beyond 90, I'm getting a little bit of spit out. So I know that there's a slightly trapezoidal gap in high flexion. And so in these cases, what I want to do after that then is I want to recut the tibia. I'm going to add maybe a degree or so of extra flexion to the tibia at the back, not going to cut it more at the front. And once I do that, then I know that I'm going to be able to get exactly what I want to do. So I recut the tibia and then rebalance the knee. And you can see as I do this, now the problem stops. The tray doesn't tilt, the knee goes up into very high flexion, and I get that patella to track exactly like I want it to track. So what happens if you do this case and it doesn't run exactly like you want it to run? So you've got a really bad varus knee, you've cut the tibia in as much varus as you can get, and you can't get it to balance. You've got some laxity on the lateral side and you're tight on the medial side. And you can see here, I'm going back to my spacer, and I can see that I've got laxity now. Okay, so I'm lax on the lateral side, I'm not happy. This patient has a significant amount of varus deformity. I go back, I check all my sizes. So what I do is I go back then, because I have the same aperture at the femur, which I haven't opened up before I did my second cut, I now go back, I put it back down exactly where I want, and I change my varus valgus angle on the femur by the degree or two that I need to correct this. So you can see I'm changing my varus valgus angle, I'm cutting the femur for exactly how much more bone I need to take, and I'm then going to recut this femur in varus in exactly the same way as you'd expect. Typically, this is it just after I've recut it. So if you do the same thing in valgus, here again you see a significant valgus knee. This is the kind of valgus knee we have in Ireland, the same as you do, maybe not quite as bad. It's got a fixed flexion deformity. Using this technique, you've got to remember that valgus knees are probably slightly worse than varus knees, and the degree of variation in the lateral distal femoral angle in valgus knees is substantially higher. So if you look at the number of cases, you can see that there's a lot more cases end up with high valgus knee, with high degrees of lateral distal femoral angle in valgus than they do in varus. This is an instrument that David Beverland has developed up in Belfast to help you to correct for the severely valgus knees. Using the system that's there at present, you can only get to about 9 degrees of valgus, and I have done several cases like that. But sometimes you need to go a little bit more than that. And so this angled rod, when put into that space, can get you up to about 18 degrees of valgus if that's what you really need. So here you can see a valgus knee. It's correctable, right? Partially correctable. Doesn't fully correct for me when I want it to get out, so it's got a significant deformity. It probably will need some sort of release in standard fashion. Here you see I've got the jigs sitting again. On the lateral side, I'm only cutting 2 millimeters off the lateral distal femur, and I'm getting 9 millimeters off the medial side. So again, I'm putting that knee exactly back for the thickness of the tray that I want to put back in. I've done my cuts, I've done my conservative cuts, I've got my knee pretty close out to an extension, but I still have some laxity on the lateral side. I'm now lax on the lateral side more than tight because of the degree of correction that I've been able to achieve. So again, when I do this, I will go back and I'll do my recut, and then I'll reassess the stabilization, and now I start to get much more stable on the lateral side compared to what I was before. It's important to remember when I was talking earlier about the trochlea in the attuned knee is about 3.8 millimeters, and you can easily overstuff or understuff a patella. And this accounts for a lot of pain in patients when you do these knees. So the more accurate you are in putting in this component, the better you'll do. So there's a range of sizes, but they're all 3.8 millimeters thick. And you can just use the tibial stylus on your cutting block to be sure of what you're doing before you start. And this is the third gap. Everybody talks about flexion and extension, but balancing the patella is just as important for me as balancing the flexion gap and balancing the extension gap. We all talk about this, but you never talk about balancing the patella and balancing the soft tissue in the patella. Because if you do this, you get the patient really happy. This is the secret to the patient who forgets about their knee, is a patella that is perfect. Because the tissues around it are highly innervated, and if you get a really tight retinaculum and you haven't thought about this, they then get pain at the front of their knee, and then they won't bend their knee, and then they'll be unhappy with you. So the key to the satisfied patient is the patellofemoral joint. You don't necessarily have to resurface to achieve this. You can do this without resurfacing. I have a tendency to want to resurface my patients. It's something that I tend to do because Personally, I don't want to have to think about it afterwards. I just do the knee, and I don't want to have them come back to me saying whether they improve it or not. So you can look at the literature, and you can see really there's no difference between whether you resurface or don't resurface. But for me, I resurface because then once I've done it, I don't have to think about it afterwards if they come complaining to me of pain. Because the patient will ask you, did you give me a new patella? And I say, no. And then immediately you have a question of doubt. So I have a tendency to resurface patellas except in younger patients. The attuned trochlea is a much better design compared to what it was. It's a funnel shape, so it brings the patella down in a funnel and it allows it to track much more naturally, and it's not constrained up in the higher parts of the trochlea. It only gets constrained late when it goes deep into flexion. It's just like what you normally get in the soft tissues. So if you understuff or overstuff the patella, you can see that you increase the forces across the trochlea and you increase the forces in the extensor mechanism. So if you've got too much if you've understuffed it or overstuffed it, you make too long for the extensor mechanism to travel, the force increases substantially in the quads and in the lateral retinaculum, and the patient then ends up with pain. Similarly, if you understuff it, they have a problem with having enough strength to be able to get the knee. So then they say, well, doctor, I'm a bit slow. They can't get their extension out. And therefore, for the same reason, that's why I measure my patella exactly every time. And I upsize or downsize my femoral component to make sure that I get that patella exactly to track and that trochlea exactly where it was when I started. So here are just a couple of case examples. This is a patient who is about 10 days post-op. She's lifting her knee, she's flexing it. She's walking without crutches at this point. She goes around all the time doing whatever she wants to do. I've taken her off crutches at 10 days. I don't tell my patients no crutches at 10 days. I say the vast majority of time, no crutches. If you get tired, you get sore, use crutches. Common sense. Here's a patient who I did bilateral simultaneous knees. Again, this patient is at 10 days. You can see he's got an entirely normal gait. He has no pain. He has no limp. He doesn't give in. He walks exactly like a normal person would walk. So these are some x-rays of these cases. You can see, in this case, I've measured the angle on the left, I've measured the angle on the right. I'm within 0.1 of a degree of correction for this patient compared to the other side. You can see my patella is exactly like I want it to be. I've got the alignment and the flexion on the femoral side exactly as I want it to be. Here's a patient who I've put in a bit more varus at 6 weeks. You can see I've got the knee exactly like the pre-op x-ray was. Here's another patient who was left in a little bit of valgus, and you can see their normal side on the other side is valgus. And I've put that knee in exactly, virtually the same pressure point on the lateral side in valgus as I've done on the normal side, which is unoperated on. And again, here's a bilateral simultaneous knee with mechanical axis correction using this technique. So I've got it exactly down the middle. Just in terms of understanding concepts about alignment, I'd recommend that people read this paper. It's a nice paper done by Faraz Haddad. It explains a lot of the concepts about kinematic, inverse kinematic, all these types of concepts. This is one of my patients who is at 4 months after I've done their knee, and they're already back skiing. He says that this patient says his right knee, which is the one I've done, now turns better than his left knee. So thank you for your attention. Just a little bit of information. This is where I'm from. This is the hospital that I work. This is the area that I live. And if anybody wants to come and visit me, please do. I'd be more than welcome to have you and to show you around. Thank you very much. Sorry for taking so long.
Thank you, Dr. Hati. But are you, just a quick question, do you retain the cruciate or are you a cruciate sacrificing? Because I noticed from most of implants you're cruciate retaining, right?
So it doesn't matter to me.
Okay, so what?
It doesn't matter to me. The key to a happy knee is a perfectly balanced knee. It doesn't matter whether there's a cruciate intact or whether there's a cruciate deficient.
No, but are you a cruciate retaining?
I do both. In one hospital I have PS, in another hospital I have CR.
So do you have indications for CR and PS?
No.
No.
The key is critical surgical technique. The key is being absolutely accurate about how you do your surgery, and it doesn't matter whether you do PS, CR, CS. For me, I do rotating platform all the time, and rotating platform forces me to be very, very precise, because if I'm not precise, I get a spin out. So I have to be very precise about how I balance those knees. I have to be very precise about how I put them in, and therefore I feel I may not be correct, but I feel that I'm able to put that knee in exactly the same way as somebody else can navigate it.
I noticed that most of your knees are cementless. So do you use a hybrid sort of fixation, or did you switch to cementless recently?
I've stopped using cement for about 3 years.
Okay, because there's a lot of, we'll take the first question.
I understand about osteoporotic patients and not using cement, and I understand there is the odd occasional patient who will be very elderly with very poor bone. I will probably cement that case. But about 95, 97% of what I do is cementless, and I do about 300 knee replacements a year.
Because there was a lot of interest in cementless initially. It went down because of the initial failure rates. Then there was a hybrid fixation where the femur was cementless and the tibia was cemented. And now I think there's a lot of
So the literature is starting to turn. If you look at David Beverland's series, David Beverland has a very large series with a 98% survival at 20 years. There was a very good editorial article in Bone and Joint Surgery maybe about a year and a half ago, reinventing. So I think some of the improvement in technology and the fit, when I put a cementless implant in, I absolutely have to hammer it in. It does not go in easily. So again, that's the very important that you get your cuts exactly. It is the precision of your cuts that makes the difference. If you're lazy about your technique, it goes wrong.
So a very nice elucidated view about why the patellofemoral compartment is so important. The question here is, up to what amount are you willing to change your rotation to get at the patellofemoral tracking, and do you ever then need to do a lateral retinacular release or any distal realignment?
So rotation for me gets automatically set because I use a balanced knee. My tibia sets my femur. And because I put that tibia to exactly what that tibia was preoperatively, then I'm able to balance that knee, and that tracking happens automatically. If you do a freehand measured resection cut, you can't control this. And I find that I tend to externally rotate my femur maybe to 5 or 6, sometimes up to 7 degrees. But that is exactly what that patient needs. I never do a lateral release. I resurface a lot of my patellas. Lateral release for me is really only for a patella that started subluxed. You'll see sometimes the patella itself is completely subluxed, and the iliotibial band and the extensor mechanism are completely subluxed, and then they're fibrosed. In those cases, you have to do a lateral release. But if the patella is not subluxed, I don't have to do a lateral release.
Thank you.
Just a quick now that you're using the Attune, most of your knees were Attune.
Yes.
I understand you use Attune. Does Attune have a high flex design, or you just use the Attune RP?
So I use an Attune RP. It doesn't need a high flex. I don't need to do a high flex. How I achieve the high flex is by the precision of the surgical technique. I don't think that the particular poly makes a difference. I don't. It's really being fastidious in removing all your osteophytes at the back of the femur, making sure that you've cleared the fibrous tissue at the back of the capsule, and that you have enough clearance for that poly to go up on its own. It doesn't need a high flex poly. It just needs fastidious technique.
Okay, because I think we see more of rheumatoid knees which are more stiff. Any difference in the approach to rheumatoid knees which are stiff or deformed? Or do you, for fixation and for balancing anything that you...
So fixation for me doesn't matter as long as I have good bone quality. I still use cementless in rheumatoid knees. The only time that I would get worried is if I had a patient who was in severe varus and I had a very unloaded lateral compartment, because that lateral compartment hasn't been weight bearing for many years. You've got to be very careful in those cases. And the trick is to make sure that your tray is very precisely sized. Any undersizing of the tray will mean that has no cortical fixation, and then it will collapse. So sizing of your tray is really critically important.
Any questions from the floor or rest? Dr. Sanjay, do you use any cementless or hybrid fixation, or you're totally cemented? For cement, we're talking about knees. Cement. Okay.
I think one reason that most of the Indian surgeons are using cement is that not only the cost but also the stage of arthritis when the patient comes to us.
So excuse me, I didn't hear your
question. Quality of bone is very much poor, and we don't really depend on the bone quality.
Yes,
we have to depend upon the cement for the fixation.
Yes, I understand, and I assess the quality of the bone before I make my final decision. But to be honest with you, it's very rare. I still I'm trying to push the envelope a little bit, and I've been doing it now for about 2-3 years, and I've had no failures. And that's in about 300 cementless knee replacements a year, so I don't have a problem. And David Beverland's literature is very clear, and that would be in severe varus deformities, severe valgus deformities, a well-performed cementless knee replacement functions very well. And they will last longer into the long term because they will get bony fixation than cement. Cement ultimately fails. The initial fixation in cement is solid, and that is the best fixation you have at the start. In the start in a cementless knee, it is absolutely its weakest point. 6 months later, it's now stronger than cement if you get it ingrown. Particularly in younger patients, it's very important.
So, if there are any other questions from the floor?
Excellent presentation, James. My one query about the CR knee, as per literature is saying that the CR knee is very good at climbing upstair, patellofemoral stability, and change in the loosening also, long-term loosening of the tibial component. What do you say about the CR versus PS knee in these three aspects?
So I do my knees.
Climbing upstair is benefited in the CR knee.
The stair climbing has got nothing to do with whether it's CR or PS. Stair climbing has got to do with how
patellofemoral-
well you put your patella in.
Patellofemoral instability is also good. Stable patella in the CR knee.
I don't understand your question.
Patellar stability, the alignment of the patellofemoral stability.
It doesn't make a difference because I spend so much time and I'm so careful in how I balance my flexion gap. Every case I think about flexion at 30 degrees, I think about the flexion at 90 degrees. So therefore I know that the difference between CR and PS or CS is none because I balance my flexion gap so carefully. CR versus CS, it's all got to do with how you balance. Stability in stairs is because you get a shift in translation, and that will happen in a CR knee if you don't balance that CR knee correctly, no matter what you do.
Oh.
Yeah.
I think the bottom line is basically whether you're doing a CR or a PS, your ligament balancing and your placement of the components has to be precise. Patellofemoral forces, climbing upstairs, downstairs, I don't think will make a difference, and I think you'll agree with that. And I don't think that there's been 1 or 2 reports regarding that. But actually, if you look at the registry-wise also, Australian registry, they showed a marginal difference between the survivorship of CR versus PS. But world over, I think we are agreeing that CR and PS provides the same. It depends on the philosophy. Having said that, people are moving back from PS to CR also in certain parts of the world. So I think there are no difference. If you get your balancing right,
it's
you
the
get
balancing.
everything
It's
right.
how you treat the soft tissues. It's doing no releases. I never do a release. 0.
Thank you.
Even in severe deformities.
Yes, we disperse.
I think we should close the session now, and we can have
tea for
tea
15
and
minutes.
coffee.
After that,
and within 10 minutes, I think Dr. Redmond will be online.
We'll be joining again by the time the internet will be set, so that we will be joined live from USA for the lecture on robotics in the knee replacement. And in the morning, I've asked him to show a surgery of robotics done by the system. So he will show a surgery, explain the nuances, and what are the advantages and how to do it. So it will be technique, and the common thing is, if you try to do and go into the kinematic theory, how we cut electrically the gap, is the femur is cut in a balanced way to a proper varus cut of tibia. So it's a very different thing, but however, it is balanced well, and that works well. So alignment takes a back seat, and balancing comes as the first thing. So just remember that. Okay. Hi, Professor Dr. Redmond. This is Dr. Prasad. So, hi.
Good morning. Well, sorry, good afternoon.
Yeah, it's good evening here. we'll have discussion and have tea also, evening tea also. It looks like it's evening here.
Sorry, I'm having a little trouble hearing.
So we have got a full house here already.
Hello, check.
I don't know whether you can see the hall also or not. Can you show them the hall? And we have to announce, friends, Dr. Redmond has joined already, so you can come back with your tea and we'll go for the session on robotic knee replacement. You can hear me?
Now that you have the microphone, I can hear you, yes.
Okay, great. Dr. Dhanashekhara is he here? Dr. Dhanashekhara Raja? Dr. B.D. Chatterjee? Hi. Dr. Hati? Please join us. You can come here because we can watch the surgery from this. Dr. Mudit Khanna? Everyone will come at exactly 5 p.m. So we have got Dr. Edmund, we have got Dr. B.D. Chatterjee. He's a joint surgeon from Calcutta in India. Professor James Harty is from Ireland. He's visiting us here. He's here. Dr. Sanjay Agrawala from Mumbai, he's sitting here. And Dr. Anil Oman from CMC Vellore. So these will be the panelists along with me. Many of us are using computer navigation, but none of us has been using the robotic arm till date.
Sure.
So I think we can start with your introduction and you can just talk to us now with your talk and then you can show us the live surgery. After that, we'll have a panel discussion with all the eminent surgeons here.
Sure, no, that sounds great. So, hello everyone, my name is John Redmond. I'm in Jacksonville, Florida. I'm a total joint surgeon here. Can you hear me okay?
Okay, I'll go there and sit there. Camera आप उधर कर दो.
I'm not sure, my audio is buzzing. There you go. That's better for me.
We can hear you very well and we see you on screen, so it's okay.
So, I was asked to give a demonstration of robotic total knee and my technique. So I'm going to try to share my screen here. See if this start playing the video here, and I'll explain what I'm doing. So I just opened up the knee. I've done several different feedback after the final implants are in. I've got 2 pins in the femur inside of the incision and the medial condyle. And once that's set up, then the computer will go through an algorithm very similar to my experience with navigation, where you start taking checkpoints here, although I'm blocking it somewhat and my assistant blocks it a little bit. Here I'm taking a checkpoint on the femur. The next thing this will ask for is the center of the hip, the mechanical axis of the femur. I think I was blocking it right with that sucker tip. The next thing you'll do is take the center of the ankle by taking the medial and lateral malleoli. And then from here, I put a 90-degree bent Homan over the extensor mechanism, and then I can take my my points here. So the first point is the center of the ACL footprint. That defines the center of the axis for the proximal tibia, and then the medial and lateral tibial plateaus. And then on the, you also get an axis for the tibia for slope, and then take a center point on the femur for the mechanical axis, this white sides line. And then here we'll take the, it collects 200 points on the surface of the medial femoral condyle, 200 points on the surface of the lateral femoral condyle distally. And then flex the knee up, and I'll be able to take, I think it's 150 points on the posterior medial femoral condyle and 150 points on the posterior lateral femoral condyle. And that generates rotation of the femur. In this system, you can use 3 different techniques for rotation, but posterior condylar axis seems to have the best intra-observer reliability. And then in this system, you draw a line across the anterior aspect of the femur, and that'll give you the exit point for the femoral component, as well as define femoral component sizing. So once that's done, so that the camera person here is now focused. So after that's done, you can take the probe on the surface of the femur and make sure that your computer model matches. And so I'm making sure here that the points that I've collected do define the most distal aspect of the femur, and then we'll define the most posterior aspect of the femur on the posterior points. I think here I'm just collecting the most anterior aspect of the femur. So once I know my model's correct in the computer, I think this is an important step, so you don't get garbage in, garbage out. Then you can start soft tissue balancing the knee. I use a patient-specific alignment technique. This particular patient did not have a lot of deformity, but I try to stay within 4 degrees of varus valgus mechanical axis, but I'll leave the patient, if it's a tight varus knee, I'll leave them in 4 degrees of varus. Usually 2 degrees on the tibia, 2 degrees on the femur. So right now I'm taking around, I've got a Z retractor under the MCL, and I'm removing the osteophytes under the medial condyle and then under the medial aspect of the tibia. I think this is a fairly flexible varus knee that the patient that I'm working on right now. So once I do that, once I've cleaned out the osteophytes, now this next screen is giving me data on the soft tissue balancing. So I'll just pause it here for a second. I went a little too far, but it was a 4-degree varus knee that came out to near full extension. And what you're seeing here, this M denotes the medial side, the L denotes the lateral side. This is 0 degrees or extension, and then here's 90 degrees of flexion. So the technique that I'm using here, so I'm stressing, right now I'm stressing the MCL, and I'm starting to collect data along the medial side of the knee. And I'll stress the LCL, put a varus force on, and collect data along the lateral aspect. And I'll do this several times before I make my bone cuts to make sure I've got the soft tissue envelope defined. So this is an example of me applying a valgus stress, stressing the MCL, and then here I'll stress the LCL in that manner. Next thing I'll do, I'll take the knee up to 90 degrees of flexion. And this particular version of the software is the first generation of the software. A new software edition came out about a month ago that I like a lot more. It's easier to collect the soft tissue data much faster. But in this case, I'm stressing the MCL inflection. And I'll put that same elevator on the lateral side, and I'll stress the LCL inflection. And then typically what I'll also do is I do cruciate retaining total knees. And so in this case, I'll put elevators in the medial and lateral side at the same time and tension both compartments. And I do this to make sure that I'm not rotating around a tight PCL, because in some knees, if you just collect the medial and lateral side and don't take the PCL into account, you'll end up with a tight flexion space, because when you tension both compartments, the PCL will be tight. But in this case, these little blue dots are coming out essentially to the, you know, my 14.5 and 16.5 millimeters with the PCL intact. So that's just a double check. And then I'll also go back for a final check. I'll stress the MCL. I'm making sure this blue dot's coming out to approximately that same point. Same thing, I'll stress the LCL, make sure that dot's coming out to, again, 11.5 millimeters. And the millimeters in this system are defining the composite thickness of the tibial component. So once I feel like I've got the soft tissue data collected adequately, then a screen can be brought in and I can adjust my femoral and tibial components prior to making any bone cuts. And so this is a bit of a busy screen, so I'm just going to pause it here for 1 second. So in the upper left corner, this is the femoral component, and these are the resections on the distal femur. So right now it'd be 9 millimeter. If I left it with no, 0 degrees of Versor mechanical axis, there'd be 9 millimeters coming off the medial condyle and 9.5 millimeters coming off the lateral condyle. 10.5 coming off the posterior medial condyle, 8 coming off the posterior lateral condyle. And I put my femur in 5 degrees of flexion. And same thing on the tibia. So you can adjust varus valgus here. This is the resection depth of the tibia, and here I can adjust tibial slope. So in this particular case, after I collected the soft tissue data with the components, the way it's set up neutral, I've got a loose flexion space, and my extension space is reasonable. So for a 6 millimeter polyethylene insert in this system, which I believe is a composite thickness of 10, I want about 11 millimeters in the extension space. And for me, I'll leave the flexion space slightly looser medial, so by about 1.5 millimeters. So I'll make this number about 12.5. And then I leave the posterior lateral side with about 3 to 4 millimeters of play typically. With our original robotic experience, we tried to make the posterior lateral side the same as the posterior medial side, kind of an Insall-Kelly technique, but that ended up with tight knees that we over manipulated. I think we just tensioned the posterior lateral side too much. So basically what I'm doing, I'm just going through and making some adjustments. I think this is a size 4 femur, and in order to close down the flexion space, I think I ended up having to flex the femur quite a bit, and eventually I'll end up at a size 5 femur. I also didn't like, as I was adjusting the size 4 femur, I was taking quite a bit of distal femur. Essentially, each one of these
recording in progress.
Each one of these adjustments obviously makes changes to the soft tissue graft. And this would actually be a graft that I would be reasonably happy with, but I think what I didn't like about it was the amount of flexion on the femur, and then I was taking too much distal femur and probably elevating the joint line a bit. So rather than doing that, I eventually switched to a size 5 femur. I can fast forward it just a little bit here. There we go. You can set the computer up to make adjustments however you like, but this system has 3 millimeters difference between femoral component sizes. So as soon as I adjusted to a size 5, it left the anterior reference point intact and then filled up the flexion space. So what I'm doing now is I'm putting the femur back to 3.5 degrees of flexion and now making adjustments from here. So I'm still shooting for those same numbers, 11, about 12.5, 13.5, but in this scenario, I'm leaving my posterior condylar offset in place and I'm not taking so much distal femur. I dropped the tibia a bit, so it ended up, to me, making the knee a bit more anatomic. So once you're happy with your component position, sizing, this robotic arm will swing in. You put it about a hand breadth away from the lateral side of the patella. I use a 90-degree bent Homan with a lap wrapped around the back of the knee to a Z retractor. That way I don't have to have any assistance in the field and no one blocks the arrays. Put the knee at about 100 degrees of flexion, and from this position you can make all the bone cuts. Okay, trapped a drape there. So this, you mentioned several of you are using navigation. This is obviously the difference between navigation and robotics. Once you plan the prosthesis, now the robotic arm will come in and just make all the bone cuts relatively simply and carry out the plan that you plan, or carry out your plan. I like this technique. I've gone to probably 50 to 75% uncemented knees at this point. One of the nice things about the robotic arm is the femoral component fits very well. The tibial cut is perfect. And we're just not seeing any failures of our uncemented implants, at least in the patient population I'm taking care of. So this is the distal femoral cut. I'll polish it a few times. Sometimes the bone in the intercondylar notch is very sclerotic, and so it helps to go through that a couple times to make sure the planar cut is intact. There is a checking probe you can use if you have any concerns. Here's the anterior cut. And for me, I'll leave that Z retractor under the MCL on the femoral side. I'll make sure it's in line with the saw blade so I don't have any soft tissue injuries. Cut the medial side. And lateral side. And the next cuts will be the chamfer cuts. Posterior chamfer here. Anterior chamfer cut. And then for me, when I go to make the tibial cut, I will you check the checkpoint to make sure the array is still intact. And then I'll position that, didn't show it there, but I'll position that Z retractor under the MCL on the tibia. And then I don't cut the tibia completely in this manner, but I'll leave a little ridge around the medial side and then around the PCL. That later I'll come back and polish off. The other option would be to have an assistant come around the robot, sublux the tibia forward, and make the entire tibial cut there. So once those bone cuts are complete, the robotic arm can swing out of the way. The bone fragments get removed, remove the meniscus, and then you can place the trial implants. And then you can look on the computer screen to see how the ligament tension, or you can obviously feel the knee, see if you're happy with the balance. This is me feeling the PCL. flexion. I think in this particular case, I thought the 6mm polyethylene was slightly loose, and I ended up at a 7mm polyethylene. So this is with the 7mm polyethylene in place, and then looking at that soft tissue graph. So again, stressing the MCL, and then I'll stress the LCL. I like to have, I don't like a bunch of laxity, but I do like to have just a little bit of play. And same thing, it's a little harder to collect the flexion data with the insert in because the femoral array can drop out. But stressing the MCL and the LCL on flexion, that's the type of graph that I like to see at the end of the case, where I've got a little bit extra play in the posterolateral corner, and the other numbers are fairly similar. So that's it, and then put the components in. So that's it for the video. I'm happy to field any questions about that technique or thoughts, concerns.
Can you hear me?
I can hear you.
Yeah. So you have been doing robotics now, and before you were doing like every other person with a jig. What are the advantages you think that robotic arm provides you by shifting from manual system to robotics? What are, if you have to enumerate, these are the clear-cut advantages?
Sorry, for some reason I'm getting a lot of, my computer is just giving me a bunch of static. I can't hear you, I can just hear static.
Yeah, I'll take another mic, I think.
John, can you hear us?
I can hear you, but there's a lot of static coming off my computer.
Okay, we'll try and repeat the question. Otherwise, we will.
Whatever you just did there fixed it.
Yeah, we'll try and repeat the question. Otherwise, we'll try and type it
now
in.
I can't hear you.
You can hear now?
No, I can't hear now.